I'm Dr. Meredith Warner of Warner Orthopedics Wellness, and I'm in Baton Rouge, Louisiana, originally from Delaware. I'm also the founder of the Healing Soul, which is a shoe I developed to naturally treat heel pain, and also the Well Theory, which is my line of natural products to support and enhance connective tissue, muscle, bone, and generally feeling better, being healthier, so that we can all, end up being able to still run and race with our grandkids, play football, get off the floor, things like that, and just feel good. So that's sort of my quest, is to empower people to take better care of themselves, because from my perspective, I don't think one can fully rely on the healthcare system. So I'm trying to give you guys tools to use for better health. So today we're going to focus on autoimmune, which I see a lot of, and I think a lot of it has seen me more than I've seen that. That's a saying we use in medicine, that if you haven't seen it, it's probably seen you, meaning you probably just didn't know what you're looking at. And I think a lot of physicians miss a lot of autoimmune disorders, unfortunately. And so some opportunities to make people feel better are lost. So let's dive right into it. This is not short. That's me, but this is a better picture of me here. That's my clinic in Baton Rouge, and I have a large physical medicine component, which I think is a very important part of treating all musculoskeletal conditions, to include autoimmunity. Exercise, you'll learn, is one of your primary weapons against this. And you don't need to think about exercise as CrossFit or all those crazy protocols or regimen or all that kind of stuff. There's some basic things you can do. They're totally approachable, and I'm going to tell you about them. Right.
Kelly says hi from snow-covered Wisconsin.
Oh, we got a hello from Wisconsin. Well, hello, Kelly. I'm sure it is cooler there than it is here today. I think we're in the 80s already. All right, autoimmune basics and current concepts. Now, keep in mind, this is from my perspective. I'm an orthopedic surgeon, but I'm very involved in wellness, health, and natural medicine. I'm not a rheumatologist, but I see and treat a lot of these conditions. So that's my perspective. And hopefully you guys will have good questions. This is what we're going to talk about. I'm going to talk quickly because I know you guys have better things to do. But I didn't want to leave anything out. I'm going to talk about what is autoimmunity, what are the triggers of the diseases, what is the difference between just straight up pain and autoimmune symptoms, what signs should you look for if you think you have an autoimmune disorder, when should you see a physician, what are the treatments that are available nowadays, and then what are the side effects of the treatments, because there's an abundant amount of them. And how could you potentially manage the symptoms naturally? I'll talk about a few specific conditions, but I'm not going to get too heavy and hard into any one specific condition. But at the beginning of the talk, I'm going to review the immune system, because none of this makes sense unless you understand how your body's defense system works. So auto, of course, means self. Immune is totally or partially resistant to a particular infectious disease or pathogen. So for instance, we are immune to, I don't know, the common cold once you get it. Now the cold virus changes year to year. That's why you keep catching it. But once you're immune to something, like, for instance, I have a smallpox vaccine, being a military brat, and then having deployed to Afghanistan and Iraq, we have to have a smallpox vaccine. So I am immune to smallpox. I have a resistance that in theory is permanent to that particular disease. And the immune system regulates all of your defenses. So think of the immune system like, I guess, sort of like the Pentagon, regulating all defenses of the nation, okay? You should be able to recognize self and non-self. In other words, we should be able to recognize our own soldiers versus enemy soldiers, or spies and moles. And then if you can't, then your immune system begins to do what's called friendly fire, or you start to attack yourself. That is autoimmune. So it's basically a dysregulation of your defense systems.
You probably look like through the cameras.
Okay. Next slide, please.
So before we keep going, can you remind everyone that it's recorded? It'll be put up everywhere.
Okay. I am to remind you that this is recorded and it'll be posted on the website, so you can watch it later if it gets too long for you or you want to break it into pieces. Okay, so to understand autoimmunity, you got to understand immunity itself. What are the functions of the immune system? Well, clean up, defense, surveillance, that's an important one, and comms, or communications with all other body systems. So believe it or not, the immune system talks to the nervous system, it talks to the brain, it talks to your muscles, it talks to the heart, talks to the GI tract. The immune system is sort of ubiquitous and omnipotent and just discusses things with every other system. So there's the acquired and the innate system. Acquired sounds like what it is. You acquire that over time. Innate is your primary fundamental defense line. So it's sort of like having a lock on your door. Really, it's like having a door or walls. And then like if you have a wall around your house, if you have an alarm system, these are sort of the innate things. And then the innate communicates with the adaptive, which is the T cells and B cells that can then target treatment. So the innate system includes skin, mucous membranes, saliva, all of these different defense barriers, then basic cells that just attack anything that's recognized as non-self, sort of non-specifically. And then they create and present different chemicals and cytokines that trigger the immune system, the adaptive immune system, which then becomes more specific. And this is where your antibodies and your T cell based sort of targeted therapy goes. So as you can see, it's pretty complex. Okay, so there are factors that are in your hands to control your own immune system function. First of all, too much alcohol intake is not good for the immune system because it's cytotoxic. So it can damage all of the functionality of the immune system. And I'm talking about excessive alcohol intake. Smoking, there is no safe level. Smoking is definitely a toxin that definitely damages pretty much everything in your body. So I can't really say there's any recommended level for that. Ultra processed foods. I think we're more and more becoming aware, we being the scientific community, that ultra processed foods are really sort of one of the primary problems of society today and health today. Ultra processed foods are known to increase levels of reactive oxygen species, inflammation, altered proteins, damaged proteins, mutated DNA, things like that. So our diet nowadays, which is filled with packaged, factory-made, ultra-processed foods, has an effective effect on the immune system, which is not a good thing. And then chronic mental stress, also not good for immune system because of the altered hormone levels and the change in the parasympathetic and sympathetic balance in your body. And then, of course, my parents' favorite, lack of good sleep, which they were right all along. So if you don't sleep that proper 7 to 9 hours of solid sleep every night, your immune system becomes incompetent and you're more able to develop not just autoimmune disorders, but just to get sick in general. Okay, so the parts we talked about already, that should just be innate, not innative. That sounds like the name of a new drug, doesn't it? The external defensives, basic inflammation and interferons, natural killer cells, that's what NK cells are, and the complement system, which is a group of proteins that are always around, floating around, just ready to glom on and attack pathogens. Then, of course, are acquired or adaptive, which is your cell-mediated or your T cells, so-called because they develop in the thymus. And then your humoral or antibody-related B cells, so-called because they develop in the bone marrow. And then autoimmune comes from a defect in any of this. So any complement protein, any aspect of T cell biology, any aspect of B cell biology, any aspect of the communication between these cells, there's a million things that could go wrong. When it goes wrong, you have an autoimmune disorder. So it's important to keep everything as healthy as you can. And we're going to talk about that. So if you have immunodeficiency, you have too little defense. That's the problem with HIV. If you have hypersensitivity, you are too filled with defense, like you attack things too aggressively. This is like your eczemas. And then autoimmunity in general is misdirected or dysregulated defense, and that's everything else we're going to talk about. In general, the white blood cells should only be about 1% of your total blood volume. And then when you have growth in certain subsets, this is when you get your CBC at the doctor's office. If there's a CBC with differentiation, it'll look at the white cells and then they'll actually count how many leukocytes, or I'm sorry, how many polymorphonuclei or neutrophils are there? How many eosinophils are there? How many basophils? And there should be a certain percentage of the white blood cells. When one elevates versus another, those are markers of disease. So that's why we get CBCs. Next. Okay, the lymph system, you may know about the lymph system. You may have had a friend that had breast cancer surgery and had lymphedema afterward, or somebody that has lymphedema in general, or sometimes you feel your lymph nodes get bigger right before you have a bad cold or while you're having a bad cold. This is sort of where the immune cells are most concentrated. And it's sort of the storage depot or sort of their barracks or headquarters, if you will. The tonsils are an area of lymph storage. The thymus, this is where your T cells mature and differentiate and become activated. The lymph nodes themselves, this is what you feel when you're sick. The spleen is a huge depot of white blood cells. And then the lymph vessels, which are throughout the body, transport and circulate lymph, which is concentrated white cells. And then there's other structures, the bone marrow, the appendix, Peyer's patches, etc. All of these are just different storage zones, okay? But they can become problematic in themselves if there's an issue. Autoimmunity. Okay, so we've got self, we've got non-self, and that's the key. Your body has to have the ability to recognize cells that are its own so that it doesn't attack itself, okay? And then there are various mechanisms that we think trigger dysregulation in the system, anything from genetics or like hereditary features in your DNA to environmental triggers to infections themselves. So one of the biggest reasons we think some people develop autoimmune is because they're exposed to a certain type of virus. And then based on the antigens on that virus or bacteria or worm for that matter, they will have a similar molecule on their own cells and they become autoreactive after that. And then autoimmune disease is either organ specific or it's systemic. So some autoimmune disorders only attack one particular organ, okay? But others attack multiple organs that have similar features, okay?
Sorry.
I'll take a sip while we're waiting. All right, here's what I'm talking about when you do this. The CBC on the right side of the slide, it shows you the neutrophils should normally be 60 to 70%, the eosinophils 1 to 4, et cetera, et cetera. That's what we should look at when we're trying to determine if somebody has a problem with the white blood cells or autoimmune disorder. So the innate immune system is very fast to respond. It's your initial line of defense, so that makes sense. So if they get through the wall, think of The Walking Dead. If the zombies get through the wall, usually there's a trap of like spikes in the ground or something to get them at that point. That's the fast response, the innate response, okay? The neutrophils act as what are called phagocytes, so do the monocytes. What that means, phago is Latin for eat and cyte is cell, so they just eat the bad guy. So they basically engulf and surround the bad cell and destroy it. That's their function. The eosinophils and the basophils produce more of an allergic response or an IgE-mediated response, which is more of a chemical attack. Or like, think of the medieval castles where they dump oil on the people trying to scale the wall. So the innate system is the barriers, the skin, the mucous membrane, the cilia, sneezing, coughing, eyelashes, all of the barriers we have. If something gets through that, then you have this fast, quick response system, which is pretty awesome, your innate immune system. And that you're born with, it doesn't need to be developed. Okay, so barriers really quickly, epithelial layers, your skin, mucous membranes. The complement factors are also one of your initial lines of defense, and we'll talk about that briefly coming up. Mediators like cytokines and chemokines. So like all of the chemicals floating around that are either signaling chemicals or they actually attack things. Now, unfortunately, these can become problematic too, right? Your cytokines can end up attacking you if you have an autoimmune disorder, okay? And I put, just real quickly, that picture in there, the tight junction on the bottom, that was to remind me to talk to you guys about leaky gut. So leaky gut is when the tight junctions in your intestinal lining become disrupted because of toxic foods that are taken in, poor timing of meals, lack of fiber, things like that. And then that allows bad guys in your food sort of to get into the blood system, and then you can develop a bunch of reactivity to that. So it's important to keep the junction or the lining of your intestines intact. It's a very important first line of defense. So the innate immune system, really quickly, these are some really awesome micrographs showing white blood cells attacking cancer and pathogen cells. So what happens is a non-self cell will release what's called a pathogen-associated molecular pattern. So there are certain molecules that are only found on bugs that are not found on human cells, and they are perceived as sort of a pattern of signals by the white blood cells. So these PRRs, the pattern recognition receptors that are on the white blood cells, recognize a pathogen-associated molecular pattern, and then they say, hey, that's non-self, he's wearing the wrong uniform, let's get him. Okay, and then on the other hand, your self cells, like your own skin cells, your own kidney cells, should not be doing that. So the PAMPs, the pathogen-associated molecular pattern, the molecules on bad guys, will initiate the inflammatory cascade. And of course, inflammation is part of your innate defense system, right? So besides the PAMPs, you also have the DAMPs, which are damage-associated molecular patterns. So when you get a cut, you break a bone, you have cancer, a cell dies in you for some reason, it releases other molecular signals that the white blood cells recognize as, hey, that's a damaged cell. We need to get in there, clean it up, recycle the parts we can use, and get rid of everything else. So the PAMPs and the DAMPs, PAMPs associated with infection, DAMPs associated with injury and like innate problems with cells, are what induce the first line of innate immunity, which is inflammation. And then you either get rid of the infection and then turn into a wound healing cascade, or if it gets dysregulated anywhere along there, you get autoimmune. Okay, this involves toll-like receptors. There's a million different steps in this process that is involved in converting from the molecular signal to the actual attack. But we're going to get into this briefly later. That all gets extremely complicated, of course. So the innate immunity, cellular defense. So the cells, the neutrophils, et cetera, remember the basophils, eosinophils, mast cells, et cetera, they actually produce inflammatory cytokines. So these are the proteins that induce inflammation and help attack the pathogen or help clean up the debris of a damaged area after an injury. Okay, so they're responsible for removing substances. These are the white cells of the innate immune system, removing foreign cells, pathogens, damaged cells, et cetera. One of the main important cleanup of debris or demolition system is the macrophages. So the macrophages come in and phagocytize or engulf and eat the bad cells. And then at the same time, they start to produce chemokines, which are chemical signals, cytokines, cellular signals that go out and recruit more white blood cells to come in and help continue the job. Mast cells, which are a different cell of the innate system, produce histamine, which gives you an allergic response. And mast cells are also heavily involved in peripheral nerve pain associated with autoimmune disorders, as well as other problems, of course. PEA, which is a natural substance that we have, actually decreases a degranulation of mast cells and can help tamp down neuropathic pain. The clotting cascade is involved in this stage, or the initial innate immune system response of inflammation. This is when you form clots, okay? And that's all triggered by the complement system, the cytokines that are signaled by the damage-associated or pathogen-associated molecular patterns. So you get a cut, what do you know? About, I don't know, minutes later, you've got a clot. It's a pretty amazing system, very rapid. And then monocytes, which are big white blood cells that eventually become macrophages, and neutrophils will destroy and sequester the bad guys, meaning pus. So when you have enough neutrophils come in, engulf the pathogens, destroy them, well, that's obviously going to leave you with a lot of trash, right? That's your pus. That's when you get, you know, pimples, things like that. All right, so the pathogen receptor recognizers are the little receptors that recognize the PAMPs, will also recognize damage, and that's the DAMPs, and we talked about that. So DAMPs are only ever released from damaged or dying cells. They're never released from a normal cell. That's how the body recognizes damage from not damaged. It's sort of like you see a crack in the wall, so you know that wall is damaged. If the wall doesn't have a crack, you're probably not going to think it's damaged. All right, so just to review, we're going to go over the cells again, the natural killer cells, neutrophils, which are your normal white blood cells you think of, dendritic cells, mast cells, basophils, eosinophils, and the macrophages. And then some of the autoimmune, I guess, disorders that are involved with allergy, which involves the eosinophils, are like atopic dermatitis, Crohn's disease, and then bullous pemphigoid, which is like a skin condition. And then these are drawn to the area by what are called eotaxins, eo meaning they're just from the eosinophils, and they're little chemicals that bring in bad guys. And then there's a receptor on the eosinophils. So once the eosinophil system gets dysregulated, then you get all these autoimmune disorders of proliferative, I guess allergic, almost like an overabundant amount of cells, and it causes like IBD type symptoms or Crohn's disease in the gut or atopic dermatitis, which is very common in kids. But that's the eosinophilic based disorders. Each type of white blood cell has its own type of disorder.
You're getting a lot of thank yous for teaching us.
Oh, you're welcome. People are thanking for this. I appreciate the appreciation. All right, macrophages. So macrophages are hugely important. They present antigens, okay? And we'll talk about antigens soon. You probably heard of antigens this past 3 years, right? So macrophages will present the antigens to the other white blood cells and then turn on and help, I guess, guide the adaptive immune system. And then they also function in the cleanup process, right? Creating pus, engulfing the bad guys, destroying them. Basically the demolition of the area of injury or what's been infected. Okay, so macrophages function in both the innate and the adaptive immune system. They come from the bone marrow. They come from what's called granulocyte macrophage stimulating factor, which is, of course, another chemical protein that the body makes that will actually stimulate certain stem cells, progenitor cells, to become monocytes. When they become a monocyte, they get into the blood, and then they're stimulated by further chemical messengers to become macrophages. So basically from stem cell in the bone marrow to monocyte to macrophage, okay? Very important in inflammation. Phagocytosis, when they engulf the cell and destroy it, uses basically, think of it like battery acid. Like there's little lysosomes inside the macrophage. When the pathogen gets eaten by the macrophage, it dumps the battery acid on the bacteria, and that's what kills it, of course. Well, now you got a macrophage filled with dead bacteria and battery acid. So that's no good. This triggers the macrophage to basically self-die in some cases. And then more signals are sent out for more cleanup cells to come in and recycle the usable parts and get rid of everything. And then, of course, you're going to have more reactive oxygen species. That's what the ROS is. Nitric oxygen species, or NO, and then halogenating radicals. So these are all just different byproducts of this process of killing the bacteria. And of course, you don't want too much of that around because eventually it's going to damage you, correct? Yes. So we don't want a lot of that. One of the biggest problems I see, I treat a lot of diabetic foot ulcers and diabetic ulcers in general. The wound of a diabetic always stays in this phase of macrophage function. And you're going to learn there's pro-inflammatory and anti-inflammatory subsets of macrophages. After the initial cleanup process, engulfing, destroying the bacteria, there should be certain signals that are sent out that then tell the macrophages to differentiate into a more of a remodeling type of a macrophage rather than a demolishing type of a macrophage. Well, in a diabetic foot ulcer, it never converts. And they're always just damaging. The wound never heals. So a lot of our treatments like amniotic live cell tissue grafts, things like that, convert the bad macrophage, the pro-inflammatory M1 type, into a good macrophage, anti-inflammatory M2. So macrophages are important in both initiating inflammation and also self-regulating and stopping inflammation and moving on to remodeling and healing. If that gets dysregulated, you got another problem. All right, so here's just some pictures showing you the M1 and M2 subtypes of macrophage. And then there's also in the T cells, there's T1 subtypes, T2. So this is how we sort of differentiate different groups that produce different chemicals that are either helpful or harmful over time. All right, so the dendritic cells, dendrite implies branches. So dendritic cells are in the lymph. They're antigen presenting cells. So they come to the T cell and say, hey, T cell, here's a part of a virus. Do you happen to have a receptor for this? And can you go attack the rest of them, please? That's the antigen presenting cell, or APCs. So a dendritic cell is one of these. So they activate B cells. They can activate natural killer cells. They can activate macrophages, eosinophils, and T cells. T cells, not cells. They're fundamental to the memory and tolerance of your immune system. Now, if you lack memory, then every infection is going to be a new infection. It's going to take weeks to mount a response. If you lack tolerance, then you're going to attack yourself. So again, here's another point of failure that could potentially happen to cause autoimmune, right? They respond to viral infections, and there's mass production by dendrites, or dendritic cells, I should say, of type 1 interferon. Interferons are the chemicals that the body makes to kill viruses. Obviously, if you have too much of it, it could be a problem. Neutrophils is the most common white blood cell. We talked about this. This illustration shows you that engulfment, that phagocytosis. So it comes into the cell. It gets recognized, the lysosome that's filled with the reactive oxygen species, the hydrogen peroxide, whatever, battery acid, so to speak, goes in, kills a cell. Then you have a lysosome filled with a bunch of crud And then that needs to be removed by macrophages or other cleanup cells, put into the lymph, and then eventually excreted somewhere. Okay, these are polynuclear, so they have multiple nucleus inside the cell, and they only live for about an hour to 2 days, so very short-lived. They're the very first cells to reach the immune focus zone. So wherever you got injured, wherever the infection started, these are the first guys. This is the first line of defense, the tip of the spear. They usually die, so they're like suicide bombers. They usually die once they destroy the bad cells. So like I said before, you got the dead bacteria, now you got the dead cell, plus you got all the chemicals. So you basically have like an EPA disaster zone cleanup site. And then what are you going to do? And if it never gets cleaned up, that's when you get chronic low-grade inflammation, oxidative stress, and autoimmune disorders. All right, mast cells. These are found in areas very close to the external environment. And this is probably one of the reasons that mast cells are involved in peripheral nerve sensitivity or neuropathic type pain, because anywhere peripheral is going to be closer to sensory bodies, nerve system. So they're found in the skin, the mucous membrane, the GI tract, the respiratory tract, and they are activated when IgE binds, okay? Immunoglobulin E. And then granules, little packets, inside the mast cell are released once they're activated, filled with histamines, which, you know, most allergy medicines are antihistamine, right? Zyrtec, Claritin. So you're trying to cut down on that protein. Tryptases, chimases, anytime you hear ACE, that's an enzyme that's usually involved in destroying some sort of a protein. Carboxypeptidase and heparin, which heparin's a blood thinner. And then mast cell activation also activates the most important, well, I don't want to say most, one of the most important enzymes in inflammation, phospholipase A2. And this is when the membrane lipids break down, and you either go down the arachidonic acid pathway, which is highly inflammatory, or you go down a more anti-inflammatory pathway. That's going to depend on your omega-6 to omega-3 ratio, which we're going to talk about when we get to the natural medicine treatments. But basically, when you go down the arachidonic acid pathway, this is when your cyclooxygenases kick in and create prostaglandins. So phospholipase A2 is turned off by steroids. Cyclooxygenase is turned off by most non-steroidal anti-inflammatories. Okay? That's how all those drugs work. So they're actually turning off this pathway that's turned on by the white blood cells. And then, of course, the mast cells will recruit and activate even more white blood cells. So the whole system is dependent on communications, recruitment. It's a pretty awesome system, but it needs to be controlled and regulated, which means you need to be healthy. Basophils. So these also are filled with granules. So they're like little attack cells. Histamine, heparin, interestingly, serotonin, which is also one of the primary chemicals in the brain and often associated with depression. And then leukotrienes, which are a type of, they're sort of, I guess, parallel to prostaglandins. They're just very damaging molecules that induce inflammation. So these are responsible for like sneezing, itching. When you have bronchospasm and asthma, swelling, you may have some sort of basophilia or an increase in the number of basocells. And then, of course, all these substances that are released. So they migrate to the area that's damaged or infected. Remember, DAMP and PAMP. So the molecular signals come out and they migrate to that area, and then they recruit more cells and cause even more inflammation. So you could see this cycle could potentially go on and on and on if it's not regulated at some point. And in autoimmune type disorders, that regulation seems to be messed up somehow. All right, cytokines. This is what these cells produce. So when you hear the term cytokine, like cytokine storm that you heard about in COVID, when you have a cytokine storm, you have an abundant hyperproduction, unregulated, of these attack proteins. Okay, the IL-1 superfamily, the tumor necrosis factor superfamily, IL-17, IL-6, type 1, type 2. All of these different cytokines will lead to different autoimmune disorders, and then usually there's some sort of combination. So these are the problem proteins that are actually doing the damage. Next.
Could you just tell Penny? She has a question about a specific drug, and that if she could just hang tight.
Oh, Penny has a question about a specific drug. I'm going to get into treatments and generally how the treatments work and what they're going to target in a little bit. So I'm hopefully going to answer your question. If you just hold on, and I'll be able to, it'll make more sense once I get through this part.
But we're saving it.
But we're what?
We're saving it for her.
And we're going to save your question if we don't answer it. All right. Natural killer cells, very nonspecific. They just detect and destroy generally cancer and virally infected cells. So there are different molecular pathogen-associated molecular patterns. There's different PAMPs produced by a cell infected by bacteria, a cell infected by a worm, a cell infected by a prion, a cell infected by a virus, etc. So the natural killers like to go after viral infected cells or cancer cells. Okay, so if you have a deficiency of your natural killer cells, you're more likely to develop cancer, obviously, and you're more likely to not successfully mount a response to a viral infection. How do they do it? They use a protein called a perforin, which literally perforates the cell wall of either the cancer cell or the virus cell, makes holes in it, and obviously a cell without an intact cell membrane isn't going to last very long, and that's how they kill. So they're basically putting a bunch of bullet holes in these things. Natural killer cells are hugely important. The complement system, very briefly, these are distinct plasma proteins. They're in you right now. They're floating all around your blood system, just hanging out and waiting. When activated, they will react with each other and they opsonize pathogens, and then they also induce or cause more inflammation. They produce proteases, which are enzymes that damage proteins. For instance, pepsin, which starts out as what's called pepsinogen, which is a zymogen or a pre-protease, and then it's activated to pepsin by stomach acid. Probably why, what's the pink stuff called? Pepto-Bismol, PEP, okay? It has to do with the stomach and stomach acid. These are everywhere all the time, but they're just unactivated. So they're sort of like, I guess, off-duty police officers maybe. And then if they're on call and they get called in, suddenly they're activated and then they have to do their job. They also make pores, but they don't use a perforin. They use something called a membrane attack complex. End of the day, they're still shooting bullets in the bad guy. The opsonins bind to the pathogen and make it a target. So this is, I think of this like a scout sniper going out and using a laser beam to put a target on something. Then the bomber comes in and has that target and attacks it. So complement lets the white blood cells target things better. They're always around in your blood system everywhere. So whenever you get infected, however you get infected, they're going to be able to respond very quickly, unless you have a complement system problem. And then they themselves, through the membrane attack complex, can damage the bad guys. So complement, very important to the innate immune system. And also the clotting cascade. Here's all your different complements. I only put this table here just to show you the ridiculous number of them and how complicated it is. They're usually confined to the cell surface. And this is one of the main mechanisms the body has of using non-self recognition and converting that to defense. So when the complement recognizes non-self or the damaged cell or infected cell, it'll send a message out saying as such, you know, out peripherally, almost like sending out a satellite signal. And they are able to be triggered also by autoantibodies and as part of the immune system, innate immune system. So that's enough about complement. That could be a whole talk on itself. Let's move on. There's like 30 of them. It's too much. All right. So this is sort of showing you the process of phagocytosis. So pattern recognition receptor, that's on the bottom left, the R and the R next to the pathogen. It recognizes the pathogen associated molecular pattern. It brings the bad guy into the cell or invaginates it. Then that's called phagocytosis. So it's eaten that bad cell. Then the lysosome attaches and you have pathogen destruction. And then there's certain enzymes that are turned on, more destruction happens. And then eventually you have this packet of badness filled with chemicals and dead bacteria. And then it's eventually evacuated or exocytosis happens. It's pooped out of the cell and then engulfed by the macrophage or the major cleanup cells. This is your basic process, and it's heavily dependent on the ability to recognize that it's a pathogen. Obviously, you don't want this going on all the time. You would self-digest yourself with these white blood cells, and none of us would have ever survived. But the body has a very, very good system of recognizing self and non-self. And even when it goes wrong, you still have enough reserves left and enough functionality that most people don't die. They just have symptoms, right? But some autoimmunes can get quite bad and be mortality causing. Next slide. All right, so the innate system then stimulates the adaptive system. How does it do that? Through signaling, through presenting antigens. So complements, macrophage signaling, remember they act as antigen presenting cells as well, and cytokine signaling, sending out the chemical messengers or like calling them on the phone. A fever is caused by a pyrogen. These are secreted by macrophages. It's usually interleukin-1 mediated. That's a cytokine, remember? When interleukin-1 goes to the brain, to the hypothalamus, the temperature of your body is reset. That is a fever. This is done by design. It's a defense mechanism for a couple of reasons. High temperatures don't allow certain bacteria to live. More importantly, it speeds up enzyme action. So a little bit of warmth will actually make everything in your body work a little bit quicker. And so the tissue attacking enzymes will work faster and the tissue repair enzymes will work faster. Good moderate fever is a good thing when you're sick and you don't really want to tamp it down. But excessive fever is not good. When you get too much fever, that's when you actually damage your own proteins or denature them. So too much heat is bad. A little bit of heat or fever is obviously important and necessary. The body wouldn't have that system. But it's basically mediated by macrophages that are releasing interleukin-1 that goes to the hypothalamus. And that's probably simplified a bit too much for some in the audience, but you get the point. I know a lot of people wonder, why do I get a fever? Well, that's why. Okay, the interferon response. Remember I told you before that the interferons are the chemicals that the mast cells produce in response, dendritic cells produce in response to the viruses. Well, they are antiviral proteins, makes sense. So they detect the viral nucleic acids, which are going to be different than human nucleic acids, different than bacterial nucleic acids, et cetera, and et cetera. So it reinforces the immune response while it detects the viral proteins and then damages them. So the interferons are important for viruses. You may know people that have had hepatitis C treatment with interferons. That's why it's a virus. So you usually get interferon type treatment.
Terry says, thanks for your way of explaining and teaching us. She's going to go back and watch for reference.
Oh, Terry, thank you. She thanked me for the teaching. I enjoy doing it. Come from a long line of teachers. So I look at autoimmune as a design problem. It's sort of like, here's this beautiful system, but yet there's a million places it could go wrong. It's like it's so complex. Obviously, there's places that it could go wrong. The main fundamental question when you're thinking about autoimmune is, how do you avoid self-reactivity, but also maintain what's called clonal diversity for defense? In other words, how do you maintain a defense system that is able to recognize and attack the gazillions of pathogens out there, but yet not attack human cells? So Charles Janeway Jr. was the original gentleman that described the pattern recognition receptors. And since then, he's been proven correct, and we're evolving in our knowledge of that over time. And that is how we recognize non-self. And then the innate will bring the intelligence of that recognition. So, hey, we just saw a bad guy enter the compound. They go to the command center, tell them, the command center sends out the specific troops to attack that invader. So that's how the innate communicates with the adaptive. And this is using what's called a 3-signal paradigm, which is sort of the classic way of thinking about this, the communication between innate and adaptive. Next slide. All right, so 3 things happen. Presentation of the antigen or the antigenic peptide. Just remember, a peptide is a group of amino acids, but it's not enough of a group of amino acids to be called a protein yet, so it's called a peptide. So presentation of the antigenic peptide, co-stimulatory molecules, and then innate cytokines, remember the chemical messengers that are produced as a result of the pattern recognition activation. All 3 of these levels of signaling are needed for productive T cell activation or adaptive acquired immune system activation. Obviously, there's opportunity for mistakes to happen here. So let's move on. The adaptive immune system is a slower response, but a much more targeted and effective response, and less sort of destructive to self tissue in theory, right? If it's working properly. It's antigen specific, so it has to be activated by the presentation of that peptide or that piece of dead bacteria or piece of dead virus, okay? That antigen specific response will induce turning on and turning off of certain genes that upregulate T cell and B cell activation. Each T cell and B cell has multiple receptors, so they can recognize a large amount of different antigens. And then this is one of the ways that your immune system can adapt and overcome how the viruses and the bacteria are constantly mutating and changing, which you guys probably all have heard about that, viral mutations, right? So the virus wants to survive, so it's going to keep changing to try to figure out ways to get in and get into the host cell and live there because it needs a host cell to live. Viruses don't really do anything on their own. They have to infect something in order to survive and replicate and reproduce. So once they are damaged, they're going to figure out a way to get back in. So we then have a way to recognize that new virus with a different antigen receptor. And this is just going on and on and on. But obviously, at some point, we have a chance for self-reactivity. If any of those antigen receptors are close to what looks like a normal human cell peptide or human cell molecule, and that's when we start getting in trouble. So the adaptive or acquired immune system, remember we're no longer on the innate system. This is based on memory and it is a systemic response. It's not a local response, okay? It is driven by B cells from bone marrow, T cells from thymus. The B cells are stored in the lymphoid tissue. They recognize free pathogens and it's antibody mediated. So when you hear about antibodies, this is from your B cells. The T cells that mature in the thymus, which by the way, as we get older, one of the biggest problems with getting older is thymus atrophy, or your immune system gets weaker because your T cell differentiation gets weaker. So one of the goals of any nutrition or lifestyle program is to help your thymus stay healthy. Why? Because the immune system really is one of the keys to healthy, optimal aging. Anyway, the T cells will recognize infected cells or cancerous cells. So the B cells recognize free pathogens. The T cells recognize infected cells. So a T cell will recognize a cell infected by, let's say, Lyme, Borrelia, okay? But the B cell will actually recognize the pathogen itself. So we have two layers or areas where we can defend ourselves, which again is kind of cool, but also mistakes can be made. All right, so next. So how does a bacteria get presented? The antigen is a part of the bacteria. So it's not like the whole bacteria is brought up and said, hey, here. It's actually a bit and piece of the bacteria that has been destroyed and damaged by the neutrophil. Now, obviously, once the innate system crushes these bacteria, a bunch of different antigens are getting presented to a bunch of different cells. So your body has the ability to recognize any and all parts of a given bacteria. It's a little bit different than probably what you've been hearing about in the news in terms of antigen presentation and creating ways to attack viruses. So a single pathogen can and will have many antigens, because if you take something and you break it up to 20 pieces, well, you got 20 antigens. So the body now has the ability to recognize any one of those 20 pieces and parts if you're ever infected again with the same bug, and mount a very fast, very rapid, very strong defense. This is why the second exposure to any given disease, you usually never even know you had it, or you have such a quick and rapid inflammatory response and get better very quickly because of these antigens, the creation of B and T cells that recognize it, okay? The receptors for the antigen are created by the T and B cell, and then they're stored. Okay, that's sort of the memory, if you will. And that maturity or maturation happens in the thymus or the bone marrow. 2 trillion white blood cells, okay? And each white blood cell will recognize 1 of 100 million possible antigens. That's crazy, right? The complexity is massive. So there are 100 million committed B cell specific combinations that are created just when you're in the fetus. And then when you drink breast milk, more are created and so on and so forth. And as you're exposed to more and more pathogens, you create more of these particular B cells or particular T cells that have a receptor that recognizes a particular antigen. So the whole adaptive system requires exposure. So That's an important part I think you should remember. So the B cells are in the plasma generally, meaning blood, and they have memory. So they recognize antigens because they're, the DNA inside the B cell has been altered or transcribed such once it's presented with the first pathogen associated or the free pathogen, it recognizes it and it produces the receptor from the DNA, right? All the code's there for any receptor, but certain antigens trigger certain transcription, a certain type of receptor. And now that next time that B cell is presented with the same antigen, that transcription happens much quicker. It's like it learns how to play a score on the piano, right? Initially, how to look at the music, how to practice, figure it out. But the next time, all of a sudden, it doesn't even need the music. It's by memory. It just plays the score. So think of it that way. So specific receptors for specific antigens. And that's actually what an antibody looks like. It's like a Y-shaped thing. Next.
There are questions coming, but they're not on topic.
Okay, we're going to get to the questions when we can at the end. Next. So the antibody, or otherwise known as, or AKA an immunoglobulin, is made by the plasma cells of B cells. The plasma cell was made by an activated B cell. And then the B cell responded to specific antigen. So it goes like that. So you have a naive or immature B cell. Antigen triggers it, makes a plasma cell, and then the plasma cell spits out a whole bunch of free antibodies that then float around and wait for this pathogen, attach to the pathogen, and then trigger the adaptive immune cascade. So the IgM, the immunoglobulin M, generally stays on the B cell and it's a receptor type protein. Immunoglobulin G responds sort of to most antigens. And immunoglobulin E, remember before I talked about how that's sort of allergies and whatnot, responds to worms and gives you your allergic response to like pollen and stuff like that. IgA is in the mucous membranes. And then there's a new one, immunoglobulin D, that nobody's really figured out yet. So just as a caveat for this talk, if I give this talk in a month, there's probably going to be a whole bunch of new information. The body of knowledge is doubling exponentially. So we'll revisit this topic as things change. Next. So the antibodies will neutralize the bad guys, agglutinate bad cells or clump them all together so they can't function, and then tag them for destruction by the other white blood cells. Okay, this is how vaccination works, or old school vaccination, I should say. You get pre-exposure to a non-pathogen or a non-pathogenic virus, we'll say, or bacteria. So it's a dead one, but it's the whole virus. And then that's how the old flu vaccine, everything that you've had is a denatured or dead or inert pathogen that you put into your system. And then your body creates this antibody response to it. And then you basically have achieved that memory so that if you're ever infected or exposed, I should say, to said bug in the future, you will mount that massive immediate response of the acquired immune system. So basically the vaccine concept is really just harnessing the immune system's ability to create memory. So you create pre-memory, it's like precognition. So you have pre-memory put into your system so you don't have to have that whole sickness cascade of the first exposure to develop the antibodies. You can develop them immediately just from this dead bug that's put into the vaccine. Next. So again, B cells rely on exposure. I don't know if anybody out there is a Seinfeld fan, but perhaps you remember the Bubble Boy episode with the mother that was so scared of her kid getting sick, he ended up living his whole life in a bubble. Obviously, that's a disaster. If children aren't exposed to bugs, they don't develop healthy immune systems. It's one of the biggest problems we're seeing after a 2-year lockdown, especially for newborns and toddlers who were never exposed to other people and to viruses and bacteria. You have to be exposed to this stuff. We got to be. There's 50,000 viruses around me right now. You don't see them, but it's part of life. And if you're not exposed to them, then you can't get this antigen-based antibody development in the T cell memory, et cetera. So lack of exposure to pathogens, we think, might be one of the problems with later things like allergies and whatnot, and failure of immune system and autoimmunity. So exposure is very, very important, obviously with the caveat of you don't want to, get smallpox, for instance. Next. So T cell immune function. So you understand B cells now. B cells are, I think, antibodies, antigen presentation, okay? So the T cells, remember, recognize an infected cell. They're not recognizing the pathogen itself. So they recognize through the damage-associated molecular pattern a damaged infected cell. And that's if the pathogen successfully invades. So if the B cell system fails, if the innate system fails, now we've got the T cell backup system, okay? The MHC proteins, these are proteins on the surface of the cell that present to the T, that tell the T cell if you're self or non-self, okay? And then there's different types of T cells. There's the cytotoxic T cells. Those are the T cells that actually kill the bad cell. Helper T cells, which you either upregulate or downregulate the cytotoxic T cells, and also our memory cells. And then the regulatory or Treg cells, which help balance this whole system. One of the biggest problems in autoimmune is a lack of balance. So the body likes homeostasis. It likes to be balanced. And if you have too much of the cytotoxic, that's not good. If you have too much of the helper, that's not good. You need a good balance. That's what the Treg cells do. And incidentally, this is why CBD in the endocannabinoid system is helpful for the immune. All immune cells have a receptor for anandamide, which CBD upregulates. And that is a way to auto-regulate or balance the immune system. All right, so T cells can only recognize antigens that are displayed by these particular proteins. They're not going to recognize anything else. So they have a certain lock that's going to fit a certain key, and they're your last sort of bastion of defense, if you will. Okay, so MHC1, or antigen-presenting sort of receptor on the cell surface complex 1, if it's an MHC1, it is infected. The self cell is infected. MHC2 is a cell that indicates a pathogen has been found. And the dendritic cells are one of them that does this. So again, the 3 T cells we talked about, CD8, CD4 through 25. So if it's CD8 marker, that's just a marker on the cell surface. Generally, that's cytotoxic. So that's going to be MHC1 driven, and it will go in and destroy the infected cell. So think cytotoxic cell poison. So the cytotoxic cells are actually the ones that are going to, they're like the killer T cells, I guess. The helper T cells release certain cytokines that then activate the B cells. So the B cells can come in and help out, and then they upregulate some of the cytotoxic cells. The regulatory T cells keep it all in check. They'll inhibit the immune system on the innate side and the adaptive side to help turn from that pro-inflammatory damaging system to more of a resolving, remodeling, healing system. So your regulatory T cells may just be the key to autoimmune disorders, some people think. So now we're talking more about autoimmune. So now I've given you sort of the baseline foundation of how this can all go wrong. What an awesome system it is if you think about it, but how it can go wrong. There are more than 80 chronic inflammatory diseases. We think there's a genetic predisposition. Nobody's 100% sure about that. It may just be epigenetics or changing in a given DNA based on environment and different triggers like diet and nutrition. And then environmental modulation like viruses, okay, when you get sick. We think it affects females more than males. In fact, it's the 4th largest disease class in females. And this is when you become immune to yourself. It sounds sort of benign, but think about it, it's terrible. If you're immune to yourself, you're going to attack yourself all the time. All right, hypersensitivity. If you have a hypersensitivity disorder of the immune system, you're going to have too much of a response to any given stimuli. So you will have an immediate allergic response or an immediate asthmatic response to a certain stimuli. This is when you get those immunoglobulin E antibodies that attach to the mast cells, and then the mast cells will then release the histamine, okay, which is a protein that gives you all that irritate, all the symptoms that you can think of when you have an allergic response. This is why antihistamines help. And then leukotrienes will be released as well. Leukotrienes are what make the smooth muscle of the respiratory tract sort of contract, and that's sort of an asthma attack. And Singular blocks leukotrienes. So that's why people with asthma are often prescribed Singular. So again, you're not curing any disease. You're just blocking the particular byproduct of this hypersensitivity response. You're not doing anything about the hypersensitivity itself. Immunodeficiency, again, a lack of production or production of deficient immune cells. So SCID was a deficiency of B and T cells. HIV is a lack of T helper cells. So if you don't have enough T helper cells, you can never mount a proper defense, and there's never going to be enough cytotoxic T cells because you don't have enough T helper cells. So the entire immune system gets diminished. That's how HIV works. Which of course HIV now is a chronic disease because we have great drugs that treat different parts of the problem. And hopefully that, you know, most of the autoimmune diseases nowadays are chronic diseases as well because our drugs are pretty good.
I think you can answer this question right now.
Okay, we got a question.
It's from Cindy, and I have fibromyalgia, lupus, and RSD. Is RSD considered autoimmune?
RSD, patient, or the patient, sorry.
They can see the question.
Oh, everybody can see the question. Good. Okay, RSD is reflex sympathetic dystrophy. That's actually the old name. Now it's called chronic regional pain syndrome, type 1 or type 2. That's the new term. RSD is not autoimmune. RSD or CRPS is generally just sort of a poor neural response to something. So either a surgery, an injury, or for no apparent reason, a nerve just goes bad. And that's sort of a hypersensitive pain response where the C fibers of the pain system are messed up and also the autonomic nervous system is messed up. So RSD is generally not considered autoimmune unless, of course, you consider that the immune system communicates with everything, including the nervous system. Fibromyalgia.
She wanted to know, is there anything natural to help with RSD?
Yeah, so natural things to help with RSD, people have studied vitamin C. High-dose vitamin C seems to help. A bit controversial, of course, in the MD world. I believe it. PEA would help with RSD. The best thing for RSD, honestly, is using the limb, moving it, and moving it and working on sort of, I don't want to say mind control, but just biofeedback and cognitive behavioral therapies, things like that, to sort of tamp down your nervous system function. So like deep breathing, things like that, that upregulate the parasympathetic system and downregulate the sympathetic system. But natural drugs would be probably omega-3s, PEA, vitamin C. All right.
And then they can go back and look at your fibromyalgia talk.
Yeah, and I did do a talk on fibromyalgia also. All right, so again, the fundamental problem here is the inability to recognize a counterfeit, right? You can't recognize that's not of self, that's not a real Louis Vuitton, that is a fake Louis Vuitton. A good immune system will be able to pick up that little subtle difference between the buckles. If you don't have a good immune system, you won't, and you're gonna be dropping $17,000 for a bag that was made by a 4-year-old in a back alley somewhere, okay? So the immune system's ability for tolerance and self-regulation is massively important. Autoimmune diseases specifically now. So there's type 1 diabetes, multiple sclerosis, Graves or Hashimoto's. So type 1 diabetes affects the pancreas. Multiple sclerosis affects the myelin or the insulation put around nerve cells. Graves and Hashimoto's affect thyroid. Pernicious and your red blood cells. Vitiligo affects your pigment producing cells. Myasthenia gravis affects the nerves, and then good pastures, lung specifically. Those are your organ specific. Autoimmune, okay, so that whatever's going on, just those cells are recognized as non-self. Then you have your systemic, your rheumatoid arthritis, which affects multiple body parts in different ways. Your lupus, your scleroderma, your Sjogren's, and your polymyositis. So you can either have an organ specific or a systemic or both, unfortunately.
Is it true that most of the autoimmune diseases have several? Also, is there any way to cure?
The question is it true that most autoimmune diseases have several, and is there a way to cure? A lot of people that have one autoimmune tend to have another one or develop another one down the road, so yes. And then is there a cure? No. The only cure is really lifestyle regulation, diet, nutrition, but we look at these things like chronic diseases, but they are completely manageable in a lot of cases. So how does your immune system fail? So you either fail to delete reactive white blood cells or at least regulate them, you have that lack of central tolerance or tolerance to self. And that can happen either centrally or peripherally. Molecular mimicry, that's one of the big ones that we think is associated with viruses. So the antigens that are supposed to just look like viruses also look like, we'll say, a synovial lining. And then you start to self-attack, thinking you're attacking a bad guy. Abnormal presentation, so the antigen is presented in a weird way, such that the T cell and the B cell then start attacking yourself. Abnormal expression of that complex that's on the cell surface that lets the T cell recognize an infected cell versus normal cell. And then sometimes the self antigen will actually attach to a non-self antigen and then make it look like a self antigen. And then you're attacking, I'm sorry, a non-self, and you're attacking yourself. Overproduction of self antigens, and then just massively reproducing white blood cells such that eventually you get some that attack self. So let's move on. We'll talk about a few of these in specific. So how do you get to autoimmune, or what causes it? We think immunological, genetic, viral, drug-induced sometimes, or hormonal. And it can be B or T cell mediated oftentimes. So when the tolerance to self is broken, this is when you lack self-recognition. So with infection, when you get a virus, we'll say, you have a disruption of the cell barrier when it gets infected, and then you release the self antigen. Also at the same time, you're releasing your bug antigen, right? So you've infected a normal cell, it falls apart, it gets destroyed. Well, some of the molecules that come off of that are going to be part of the normal cell, right? And then those can then, unfortunately, not be recognized as part of a damaged normal cell, but rather get linked to the pathogen. It's all very complicated and difficult to understand, even for most physicians, including myself, but that's one of the fundamental ways that we think infections do this. And then also the pathogen can just say, oh, there's a normal protein. There's a guy going into that door with his ID card. I'm just going to walk in right behind him, and nobody will know that I don't really belong in this building. So that's another way. So they can bind to the self protein, and then the molecules are mimicked. So that's when one player on a team might wear the other team's uniform and just pretend like they're on the wrong team. And then, of course, super antigens, which just blow the system up. And then this causes polyclonal activation of T cells, or multiple T cells are activated. And then, of course, some of those are going to respond to self. So there's different ways that a virus, we think, can institute an autoimmune disorder. And there's a lot of autoimmune disorders that we think are really triggered by a virus infection at some point.
More questions about, are there natural treatments?
Yeah, we are going to talk about natural treatments. That's the whole point of this. I just have to get through the pathology so that you understand how the natural treatments work better. So here's some of your common infections and the associated autoimmune disorder that results. Group A, strep, will sometimes turn into rheumatic fever, and what's called Reiter syndrome, which is a joint inflammation. Shigella, Salmonella, Yersinia, Campylobacter. These are all bugs that hit the gut. Those sometimes turn into what's called reactive arthritis. So for some reason, these gut bugs then have your T cells and B cells recognizing joint molecules as non-self and attacking the joints. Borrelia, which is Lyme disease, again, same thing, chronic arthritis. So a lot of people that have had Lyme disease have weird aches and pains and joint pain forever, and it's really a subtle autoimmune disorder because the body is recognizing joint tissue, thinking it's the Lyme bug. Enteric, which is gut viruses, we think maybe one of the reasons people develop type 1 diabetes. And then celiac disease is reaction to gluten protein. Okay, herpes can sometimes lead to susceptibility to MS, as will vitamin D3 deficiency, which we'll talk about that. And then Epstein-Barr virus is one of the big ones. So that's mono. We think that that leads to lupus, rheumatoid, and Sjogren's. So basically the immune system is overwhelmed. There's molecular mimicry, there's bystander activation, and all those different subsets of how viruses trigger self-tolerance destruction. So psoriasis, this is a hyperproliferative keratinocyte. Okay, so your skin cells are making too many skin cells. And the skin cells are infiltrated with T cells, with dendritic cells, with macrophages and neutrophils. We think this is an IL-17 or interleukin-17 mediated pathology. And in fact, some of the drugs for psoriasis target IL-17. This affects about 2% of people. And if you have psoriasis, you don't necessarily have psoriatic arthritis. Vice versa is true too. I think it's like 10 or 15% of people with psoriasis will get psoriatic arthritis, but some people just get the arthritis and never have symptoms. This is another organ-specific T-cell mediated autoimmune disorder. And we think strep might activate the T cells that could potentially lead to psoriasis. There's absolutely no consensus there. That is not for sure, but that is just a theory to think about. And then the streptococcal M protein, okay, there's a certain protein on the strep bug that is similar in its molecular shape to a type 1 keratin protein, which is a skin protein, and that's your molecular mimicry. So when the strep bug gets killed and broken apart, one of those antigens happens to look like one of the proteins in the skin cells. And this is where you can get that T cell molecular mimicry. Oh, I recognize that skin cell. That's a strep bug. I got to get that. Well, it's not a strep bug. It's a skin cell. And then you get psoriasis.
Do you know anything about T cell lymphoma?
The question is about T cell lymphoma. That's a whole different topic of sort of hyperproliferative cancer disorders. That is not the topic of this talk. I mean, we could probably talk about that in the future, but I'm not going into that today for sure. That's way too big. So again, activation of an autoreactive T cell is needed to have an autoimmune disorder, right? So we think infections are the culprit. Some of these little peptides, remember little bits and pieces of the big protein from a pathogen or a bug, will have structural similarity to self-peptides. I just told you about one. The strep peptide is similar to the type 1 keratin protein. Inflammation will result, and then that activates the local antigen-presenting cells. Remember the macrophages, the dendritic cells. And then this enhances the processing of the self-antigens. So the inflammation from the recognition of this little protein that looks like a bad guy, but it's not really a bad guy, basically triggers a whole inflammatory cascade. And then you just have bystander activation, which is code for just enhancing the activation. And then this is essentially a recognition problem. And epitope spreading is when you have a recognized protein region or a recognized peptide that is found in multiple locations. So it's like you happen to have a key fob that turns on 7 cars when you go to a parking lot. Obviously, we don't want that. We would want it to be much more specific. So viruses trigger molecular mimicry, so they look like the molecule, bystander activation, and then epitope spreading. But viruses are one of the bigger problems, I think, with autoimmune disorders over time, okay? And then, of course, I gave you that list. My producer just left. Hold on. I'm ready for the next slide. So let's talk more about this. So the molecular mimicry, you've got the antigen presenting cell, and see those MHC complexes 1 and 2. The MHC2 will react and get recognized with, and that's T cell receptors, TCR, will recognize the autoreactive cell. And then you have the attack of self. Okay, in a similar way, you get your autoreactive T cells that go down to an antigen presenting cell and say, hey, you need to recognize this antigen. And then it'll explode the response that way. So it's like bad information in, bad information out. It's like when you tell your computer something and then you expect a good result and you just get bad answer because you gave it bad data. All right, we're back. I can go to the next slide. All right, just quickly about oxidative stress. I always harp on chronic inflammation and oxidative stress as sort of the fundamental problem of what we call non-communicable diseases, which autoimmune is one of them. Oxidative stress is brought about by mental stress, toxins, environmental pollutants, bad diet, things like that. The biomarkers of oxidative stress have been found to correlate heavily with disease activity of autoimmune disorders. So the more oxidative stress there is in your system, the more chronic inflammation, the more likely you are to have an autoimmune disease or to have a flare-up or to have enhanced activity of your autoimmune disease. And then the oxidative stress will help to mediate the organ damage that happens in autoimmune dysfunction, and it'll help to trigger the autoantigenicity. Because remember, oxidative stress is free radicals or unpaired electrons that are going to go in and mutate DNA, damage protein, damage cell membranes. Well, then guess what you're doing? Now you've got a damage-associated molecular pattern brought about just by eating too much ultra-processed foods. So the mitochondria in the immune cells will then produce too many reactive oxygen species, and you get even more oxidative stress. So trying to maintain a healthy diet, an anti-inflammatory diet, reducing the level of oxidation or oxidative stress is very important when you're thinking about naturally treating autoimmune disorders. We'll talk about it briefly at the end, but one of the best ways to help autoimmune disorders is a good, clean, healthy, whole food diet, and exercise, which helps tamp all this down, and good sleep. Next. And then the supplements that antioxidants like tart cherry extract, turmeric, things like that, omega-3, which gets you past that arachidonic acid pathway and lets you go down to more of an anti-inflammatory, pro-healing or resolving pathway. In fact, omega-3s have been studied extensively in rheumatoid arthritis and have found to be very successful, particularly as an adjunct to whatever drug your doctor is prescribing. Anything that's anti-inflammatory naturally that tamps down the COX-1 and 2 enzymes will help. Anything that helps to repair tissue, so things like ALA, which is alpha lipoic acid, will help because it's a good antioxidant for the cell membrane and the cytoplasm. PEA, remember, stops those mast cells from releasing the damaging granules that induce more oxidative stress. Anything that chelates heavy metals like NAC, which is N-acetylcysteine, or chlorella, which is a type of green algae. So there's a million ways, and we'll talk about a bunch of them at the end again, that help to tamp down this oxidative stress. Next slide. Please.
Do you like Boswellia serrata?
Do I like Boswellia? Yes, that's frankincense, and that's in one of my topical pain creams. Frankincense is a great anti-inflammatory. It also smells very good. Okay, so how do you know if you have an autoimmune disorder if you're not just told you do? Well, my opinion, the slides here, it's never really this obvious to most physicians because most people, at least in the United States, aren't getting this far in the disease process, okay? The top is a Hashimoto's thyroiditis, so thyroid is just blown up from the autoimmune attack. The middle picture is rheumatoid hand, okay? So the joints of the hand have just been completely obliterated by the rheumatoid arthritis. And then the picture of the face with the rash, that is a malar or butterfly rash, which is classically associated with lupus. Usually we catch people before this and get them treated. But those are the dramatic symptoms. Most people with autoimmune have sort of long-term symptoms. It's been unexplained. Most physicians can't figure out what's going on. They have multiple things going on in multiple different body parts. Nothing seems to match. It's all over the place. All the basic diagnostics like the CBC and the CMP have been normal or negative. Nothing's really showing up. Most of these people tend to have sleep disorders. A lot of them will have mood disorders as well. Weight can be variable, but obesity makes things worse. And then most of these people will have fatigue. So you just generally have malaise, you're tired, you have no energy. All of these disparate, vague, weird symptoms you could imagine would be hard for a physician to piece together. In my opinion, a lot of female patients, particularly if they're overweight, present to a doctor with these complaints. They're often sort of just pushed aside, I think, and ignored, and just told to go exercise and lose weight without anybody really diving into it to see if there's a unifying theory that might bring all of these symptoms together.
Tammy has a question.
Tammy has a question.
Is it okay to stay on PEA? She's possibly diagnosed with RA, but all her tests come back negative, but she has pain in the swollen index finger joint. Plus index fingers cross over now. What else? Okay.
That's a long question. Somebody's on PEA, they think they might have RA, but everything's been negative. Remember I told you this, the tests are usually negative. They have a swollen index finger joint and something about the index finger crossing over, which I'm not quite sure what that means. Can they be on PEA? PEA has been shown to be very safe, no adverse events in any of the clinical studies thus far. It's used as a first-line treatment for neuropathic pain and pain in general in Europe. So yes, I think PEA is very safe. I take it. I don't have an autoimmune disorder. I just take it for health and wellness and to sort of help my endocannabinoid system stay solid and for brain health. So yeah, you can stay on PEA. In my opinion, check with your physician. Thanks.
And then you'll get to the other ones.
I'm gonna get to the other ones soon, hopefully. My producer stays here. All right, what do you look for when you go see a doctor? So if you have symptom complexes, so let's say you have a skin rash, you have like your gut doesn't seem quite right. You either have diarrhea or constipation and your knee hurts. To me, that's a symptom complex that would speak to some type of autoimmune disorder. And if you presented to my office, I would do a full autoimmune workup. But of course, I'm asking all those questions. I'm not just going to focus on your knee. That's my particular practice because we try to do things holistically and naturally and think about the whole person. You may have to advocate for yourself. And when you see a physician say, hey, what about this rash? What about my gut problem? Do you think it could be connected to the knee? Because generally speaking, a knee doctor that's forced to see 30 to 50 people a day isn't going to delve deep into anything else. But if you have symptom complexes, that's usually a sign. Maybe you want to go see a rheumatologist or at least somebody that thinks about these things. If you had a prior viral infection and all of this happened, if this has been going on for a long time with no particular reason, if you're not responsive to basic treatment, like you took ibuprofen, it didn't help. You started sleeping better, it didn't help. Nothing's really helping. And then you have an unclear picture and you're just filled with doubt. You doubt yourself, you doubt your doctors, you don't know what the heck's going on, you doubt the system. That is a good sign that you have autoimmune disorder. I happened to look something up on Reddit to see what people out there associate with autoimmune, and there were literally 454 symptoms listed. So unfortunately, it's very vague, it's very nebulous, but I think if you find someone that'll help you think about it thoughtfully and run the right tests, you could potentially come up with the right diagnosis. And hopefully you don't have an autoimmune disorder. But if you do, there are ways to tease it out. Okay. How can you differentiate it from something else? This is where the art of medicine comes into play. Now, maybe there will be an AI chatbot that'll figure this out for you in the future. I don't know, probably. Right now, I need to take a really good history from you if you present to my office. Ideally, you actually put your hands on the patient and do a real physical exam. And I know a lot of you out there are probably thinking, gosh, no doctor has ever physically examined me. That's true nowadays, I think, unfortunately. But a good physical exam will teach you a lot about a patient and help you with the diagnosis. You got to run the right lab work panel. You have to think to order an EBV panel or a CMV panel or look for Lyme disease. You need to run the inflammatory panel. You need to look at their omega-6, omega-3 ratio. So the proper lab work must be done. Then you can do imaging if you're looking for things like joint destruction or different little hallmarks of different rheumatologic diseases. In other words, it takes a lot of work. It takes a lot of time. And this is one of the problems, as you know, in medicine today. Nobody puts in the work and nobody puts in the time anymore. And it's unfortunate, but that's the world we live in. That's why I'm doing this, to help you so that if you think you have a problem, you know what to look for.
So review the blood work, the things.
Oh, they want me to review the blood work, but I'll tell you, there's just a million panels you can
Or
run.
whatever you just said there, because they can't read that.
This blood work? Oh, on the right. So this is like when I order an Epstein-Barr virus panel, it'll look at the nuclear antigen 1 IgG, the immunoglobulin G, which remember reacts to most antigens. It'll look at the VCA, which is a different type of IgG antibody. It'll look at the early activated or a different type of antigen off of EBG or EBV. And then it looks at IgM, which is a bit more of an acute response. And then it'll look at antibody response. So anyway, the whole point of this is if you run a good EBV panel, you can determine if they had EBV previously and it's latent, they had it before and it's acutely flared, or they're susceptible to it now, or they're recovering from a recent infection. So there's ways to tease all of this out. So a lot of times if somebody has all these disparate symptoms, I'll run an EBV panel if it ends up being positive for either acute reactivation and they have symptoms that remind me of lupus or RA, I'll then delve down that pathway. But that's just one thing to do. Okay, common symptoms of particular autoimmune disorders. That's what AID is. So if you have a goiter, a thick neck up here, and you're feeling fatigued, listless, you're losing hair, cold intolerance, all that kind of stuff, you may have Hashimoto's disease. Incidentally, Hashimoto's was first described in 1912 by a Japanese doctor, Dr. Hashimoto, ignored for a while. And then when Johns Hopkins reported it again, I think in 1928 or 1929, something like that, then we regained interest and we learned a lot more. The bottom right picture shows you the immune cells attacking the thyroid. Not a good thing. Most cases of Hashimoto's will burn out. It's actually very common. And then when your thyroid burns out, you have to go on Synthroid, which is a synthetic form of the thyroid hormone. Polyarticular pain of gradual onset. Different joints hurt at different times, and it's progressive, and it kind of gets worse. It kind of comes and goes. You don't really know what's going on. That's sometimes a marker of RA, rheumatoid. Fever, rash, fatigue, and malaise, lupus. Okay, if you get loss of vision, loss of power in an arm or a leg, some numbness associated in the limbs, that's sometimes a sign of the autoimmune against the nerves, or MS. And then some people with joint pain with stiffness and swelling, dactylitis, which is a swollen individual finger, with or without a skin rash, is sometimes a sign of psoriatic arthritis. So there's different groups of symptoms that we are supposed to look for to sort of guide our brains into which diagnostic pathway we want to follow. Unfortunately, there's a lot of overlap of all of these. So it's very, very complex. I'm not going to go into this too much. Let's get into the disease specifics. So type 1 diabetes. This is when you attack your own beta cells of the pancreas. The pancreatic beta cells are what make insulin. So if you attack your insulin-producing cells, eventually you don't produce insulin. Thus, type 1 diabetes. 1% of the population, we think, gets this. Normally, the rate of proliferation or growth of beta cells in your pancreas is controlled by the level of glucose in your system. So you have a good feedback loop in your system as to how much insulin you're going to produce at any given time based on how much glucose is in the system. Well, if you have no pancreatic beta cells, you can't respond to any glucose in your system. And then you get all the problems of hyperglycemia, to include diabetic ketoacidosis, which can put you in a coma. What is the treatment for type 1 diabetes? At this point, symptom management. You just give them insulin. The thyroid. So again, Hashimoto's. So there's other endocrine or hormone autoimmune disorders. So there's a thyroid, which can be Hashimoto's or Graves' or myxedema. Pancreas is an endocrine. We talked about that. The adrenal gland, if you self-attack, you can end up with what's called Addison's disease. The gonads, you can end up with orchitis or an inflamed testes, or oophoritis, which is inflamed ovaries. And then the pituitary gland, you can get multiple different disorders if you attack your pituitary. But Hashimoto's, I mean, here's your common symptoms. Pale, dry skin, memory lapses, brain fog, depression, the tongue gets a little bit bigger. You have muscle aches, you have weakness, things are tender that shouldn't be tender. You feel stiff in joints for no apparent reason. Sluggish, you don't like being cold at all, and you have unexplained weight gain periodically. Those are all signs of your thyroid being dysregulated. Remember, the thyroid has receptors really just about everywhere in the body. So if your thyroid goes down, you do tend to have a lot of systemic problems. So this is something we often look for, particularly in women, particularly in the middle age, who come presenting with these vague, weird, bizarre symptoms. One of the first things we do is check a thyroid panel. Standard treatment, thyroid hormone. Just like with pancreatic beta cell death, we give insulin. Again, we're not treating the source of the problem, right? So you basically replace the thyroid hormone when it gets burned out. That's all we can do with this. This is state of the art right now. Next slide. Rheumatoid. Okay, this is an interaction of immune cells and fibroblasts, which are often found in connective tissue, particularly joints. The T cells, and particularly the T helper cell type 17. Okay, rank L is the receptor for nuclear factor kappa ligand. That is an NFKB, which if you watch any of my other talks, the nuclear factor kappa beta is a transcription factor that turns on inflammation. So there's a receptor that turns it on. In rheumatoid arthritis, you have increased number of those receptors on the synovial fibroblasts. Synovial cells line joints. So this is why it's polyarticular, or affects multiple joints. You eventually produce more of what are called metalloproteinases, which are ways to destroy the proteins of bone and cartilage. So you get bone destruction. The synovial lining is fully dysfunctional all the time. It gets very thick. And then bone formation gets disturbed. And so a lot of people with rheumatoid arthritis is untreated. If you take x-rays, their joints have holes in them. There's erosive cysts. It's just a big mess. Because of the bone destruction associated with the cytokines that are produced by the dysregulated T cell mediated system. Rheumatoid factor is an autoantibody that we look for when trying to diagnose this, but I'll be honest, rheumatoid factor is present in about 15% of the normal population. So this is why sometimes even when you have a rheumatoid factor, you go see a rheumatologist and they say, you don't have rheumatoid. I'm going to tell you why in a minute. They tell you that. And then of course you get resident memory in your CD8 cells. And if you recall, the CD8 cells are cytotoxic. So these are designed to recognize synovial lining fibroblasts and attack. So rheumatoid is a chronic disease whereby you're attacking your own joints and connective tissue. Remarkably unpleasant, obviously. Okay, this is why your doctor typically won't tell you you have rheumatoid, even if you think you do or another doctor thinks you do. You have to meet they basically created this is where AI is going to come in. If you don't meet this algorithm, you don't have RA, okay? So you have to have numbers 1 through 4, all of them, for 6 weeks or more. And then you must have 4 or more of them in general. This is the American College of Rheumatology criteria as of 1988, okay? I think the next slide gives us the updated one, the 2010 criteria. Let's go to the next slide because I'm just showing them the old criteria. Yeah, this is the newer rules so look at this. Look at this algorithm. This is why you don't get told you have RA. So you have to score greater than or equal to 6 points. You must have had at least 1 swollen joint, not better explained by something else. And yes, you have been reduced to a point system. So you could show up with your toes looking like that, but if you don't get the right number of points here, you're not going to be told that you have rheumatoid arthritis. It goes with symptom duration, how many joints are affected, what is your blood work showing, and then your inflammatory panel. So you have to add up a certain number of points in order to meet the criteria of having rheumatoid, whether or not you have rheumatoid factor in your blood. Lupus, similar. You have to have an ANA titer of at least 1 to 180 on a particular type of cell at least 1 time. And then you have to have another group of criteria and a certain point system. For lupus, there are 7 clinical domains they look at, 3 immunologic or like blood work domains. You have to have 1 of the clinical and 10 plus points. So again, a point system to be diagnosed with lupus. So we think lupus comes from epigenetic alterations. This is when you have DNA, you have a certain code in your nucleus, but there are switches, there are on-off switches on certain portions of the DNA. If the wrong ones get turned on or turned off, you can end up with lupus. So it's not necessarily the genes themselves, it's the epigenetics or the methylation of the DNA. And that can be affected by your diet, by your toxin exposure, by mental stress, things like that. If you have certain vitamins or minerals in low supply, you can have epigenetic alterations. Again, thought to be triggered also by environmental and hormonal factors if you're susceptible. So if your genes and your epigenetics are in the right position and then you get exposed to EBV, you could end up with lupus, okay? Recurring environmental factors seem to be important. It's very pro-inflammatory, loss of tolerance, which we know that, and we think T cells play a big role, okay? And then there are defects for lupus in both the innate and the adaptive. So it'll hit sides of your immune system. And lupus has multiple different subtypes. This isn't a talk specific to lupus. Okay, so hyperactive B cells, remember the B cells recognize pathogen, produce antibodies. T cells recognize an infected cell or a damaged cell. There are more antibodies in a lupus person. Hypergammaglobulinemia, or too much protein floating around in your blood. More IL-6, interleukin 6. This is one of the inflammatory markers I look for. And ironically, more IL-10, which is actually anti-inflammatory normally, but it can promote more B cell activity. So you could look for IL-10 too. Again, the T helper cell number 17 and the T helper 2 regulatory helper cells are implicated in this. And so some of the drugs will target T helper cell 17 and downregulate that cell population. These are the symptoms associated with lupus. We always think of a rash with lupus. It's usually associated with fever. People with lupus tend to clot their blood a bit more than others. There's a lot of psychological side effects, muscle aches and pains that are unexplained, bone aches and pains, different mouth and nose, also like mucous membrane breakdown or breakdown in your initial line of defense. Arthritis is associated, poor circulation. And yes, can you have lupus with Sjogren's or with Raynaud's? Yes, you can have multiple types. Okay, so GWAS is a genome-wide association study. So this is new technology that we can do now where scientists will just basically run the DNA of, let's say, 100 people and see which one is, and then a computer will match up the genes and say if any of the genes are associated with people with lupus. So it's correlated, it's not causative. However, we have found 100 associated genes with people with lupus in these genome-wide association studies. But again, the bigger role is your epigenetics, and you control your epigenetics. Think of this, less than 10% of all of your problems are from genes that you have no control over. 90% you have complete control over. Environment, epigenetic modification, controlling your oxidative stress, controlling your chronic inflammation. So the DNA of a lupus CD4 cell, remember that's your helper T, is hypomethylated. So the DNA has epigenetic changes that make it dysfunctional. It doesn't work right. And then, of course, oxidative stress will make it worse, the lupus worse.
Does NMN affect the epigenetics?
Yeah, so NMN, which is nicotinamide monodinucleotide, I think, it's a precursor of NAD, which is one of the primary electron shuttle mechanisms of the cell. Well, NAD also turns on and off sirtuins, which are proteins that help repair mutated DNA. So in a way, yes, you can affect the function of the DNA by making sure your DNA is pristine in and of itself. But NAD is primarily an energetics thing that just helps the cell function in general. Methylation of DNA is generally from like poor diet, ultra processed foods, being exposed to pollution in the air, smoking, things like that. So other factors at play, well, we just talked about this already. Someone, great question, whoever asked that. We already talked about you can smoke if you want, but you're likely to get lupus more likely than I would be because I don't smoke, okay? Drugs can induce this, adaptive immune system dysfunction. Sometimes this is called, this is my favorite, when I see patients that I think have an autoimmune, I do the workup, they have the symptom constellation, they have certain markers in their blood, I send them to rheumatology because only rheumatologists are allowed, at least in my state with the insurance companies the way they are. Like I can't give somebody Humira, for instance, you have to be a rheumatologist. So I'll send them to a rheumatologist and they're told, nothing's wrong with you. So they come back to me. So this is when you get called undifferentiated connective tissue disease or mixed connective tissue disease. Basically, in my opinion, this means that we physicians have no idea what it is. So we don't have a name for it yet, but something's wrong. We just don't know what to call it. So that's probably a lot of you out there because I have a lot of patients like that they don't meet that specific criteria for rheumatoid. They don't meet the specific criteria for lupus, psoriatic arthritis. And if you don't meet this specific perfect criteria, the identity, then you're basically nothing in the rheumatology world, right? But to me, you still have a ton of symptoms. So we still have to treat it. I'm gonna talk about ways to treat that. I have a lot of patients with MCTD or mixed connective tissue disease. The ANA is often used to test for these things, but it's very non-specific. If you have a positive ANA, you got to look at how much is positive. That's that titer. And then delve into the other things like check their complements and check other inflammatory markers. So Epstein-Barr virus, we think, has a big role in lupus. High viral loads of the DNA of Epstein-Barr virus have been found in people with lupus. High titers of the IgG and the IgA. Remember, we looked at that EBV panel. So the anti-early antigen EA. So high titers of these have been found in people with lupus, and then also in people with rheumatoid and Sjogren's. So if I think somebody has lupus, Sjogren's, rheumatoid, et cetera, one of the things I order is an Epstein-Barr virus panel, just for the information. Now, will it change treatment? Probably not, but at least kind of gives you a clue. And then the antibodies cross-react with the lupus autoantigens. So that's the problem. So you get that molecular mimicry, that epitope, the spread of the autoantigens. So basically the Epstein-Barr virus makes your self-tolerance lower. Okay, what are the standard treatments of lupus? So immunosuppressives, of course. One of the main problems with lupus is kidney failure. We don't want that. So to prevent organ-specific total breakdown, you do need to control this disease. So that's where immunosuppressives come in. About 60 to 70% of people respond to these. So think about it, that's not that great. 70%, that means 3 out of 10 don't respond to the immunosuppressives at all. This is where cocktail treatment comes in. So let's talk about pharmaceuticals. And I have a list of a lot of drugs, but I'm going to talk about a few of them here. So the goals of treatment of autoimmune, so think about this in the back of your mind. You either reduce the inflammation, you reduce the pain, you manage the symptoms. My goal, and the goal of a lot of physicians, is to improve quality of life. That's what QOL is. Ideally, you prevent or at least delay organ damage. And then there's a couple of ways to do this. You either replace what's missing. In the case of Hashimoto's, you give them thyroid. In the case of type 1 diabetes, you give them insulin. you immunosuppress to sort of try to control the disease, but we never cure it. Okay, so the immunosuppressives used to be very non-specific. Now we're getting a little bit more specific with the biologics and the different DMARDs. So the non-specifics interfere with large pathways in many cells. So think of the steroids. They block phospholipase A2, which is the first enzyme in that sort of global inflammatory cascade. So this is why prednisone is used and has been used for hundreds of years for autoimmune problems. So you're not treating the disease, you're treating the symptom of the disease, which is inflammation. Okay. And of course, steroids have a ton of side effects. So ideally, you don't have to be on steroids, you aren't. Now we have more specific and stronger ones like Humira, which we'll talk about. And then ideally, if you catch people early and suppress this immune system early, you can actually put them in remission, but the disease is still there and can come back latent or rebound. The problem with immune suppressants is infection, right? If you suppress your immune system to control an autoimmune, well, you're more prone to getting sick, getting disease, getting cancer. Okay, so the targets of the treatment. So drugs can target different things. They can target the macrophages. Now you understand how the macrophages play a role. They can target the T cells specifically. A multi-prong or cocktail approach seems to be the most useful. Our goal would be to upregulate the good T cells, like the T helpers and the T regs, and to downregulate the cytotoxic T cells. And then different drugs work for different people on different diseases. This is why a lot of people go through multiple drugs until they find the right one or the right group of drugs to help them. We don't have any genetic tests that say, you have psoriatic arthritis and this drug is for you. That just doesn't exist yet. It'll probably come at some point, but we don't have it yet. For instance, 70% of people with rheumatoid arthritis respond very well to methotrexate, which has been around forever. An anti-tumor necrosis factor, certain ones will help in rheumatoid, but they don't help people with Crohn's. On the other hand, infliximab helps people with Crohn's, but doesn't help people with rheumatoid. DMARDs, which are disease-modifying anti-rheumatologic drugs, fail in rheumatoid arthritis about 3/4 of the time over 5 years. So that's not good track record, right? So even if you have a hugely successful drug, you have a 3 out of 4 chance of that drug failing you after about 5 years, and then you'll have to change medications. This is a very common scenario in autoimmune. The dosing, highly variable and empiric. That means sort of just guessed. Nobody, just play with the dosing until you get it right. Methotrexate generally is 7.5 to 15 milligrams per week. Cyclophosphamide is weight-based. And then really the way that people dose these drugs is you start small and then you try to get as much drug in the person that will control the symptoms without becoming toxic to the person. So therapeutic toxicity is sort of what makes the dosage the dosage. And that's why you have to keep going back and checking biomarkers and making sure everything's okay. So you're looking for side effects while you're also keeping inflammation under control. Sounds like we have a question, perhaps.
Will Rinvoq set up for cancer? She has.
Will Rinvoq?
Rinvoq.
Rinvoq. Any immune suppressant could theoretically increase your risk of cancer, but generally, if physicians are looking for these things and they're dosing you appropriately, where you still have a decent amount of immune function, but in an ideal world, you wouldn't be on any immune suppressants, right? Because you need your immune system to recognize a mutated cell and get rid of it before it becomes a cancer focus. And that's a whole nother talk, but any of these anti or immune suppressants can put you at risk of getting sick when you wouldn't get sick, or having damaged cells proliferate like cancer. Now, is it a 1-to-1 ratio? I don't know. You would have to talk to whatever rheumatologist prescribed the Rinvoq.
She's desperate for your advice on the natural treatments, so just reassure them.
Yeah. We're going to get to the natural treatments, which natural therapies, I'm a big believer in them, obviously. And if a lot of people that have particular lifestyles and have the right amount of micronutrients tend to not get autoimmune disease, the natural stuff certainly, I'm not going to say cures the autoimmune, but it definitely makes all of these drugs work better for you. So it definitely helps with remission and symptom management and all of the pain associated and the itching and the rashes and all that associated. You're never going to cure the disease, but you can massively control it with environmental and lifestyle. And we're going to get to all of that. So the DMARDs, the disease-modifying anti-rheumatic drugs, slows the progression of the disease. Note, I don't say cure. So they're remission-inducing drugs. They'll lower the erythrocyte sedimentation rate, which is a marker of inflammation. They'll improve the anemia that's often associated with these diseases. They'll lower the level of the rheumatoid factor, or that antibody in your blood level. They'll lower the C-reactive protein, again, another inflammatory marker made by the liver. And ideally reduce the rate of damage to cartilage and bone. So I can tell you, when I started my training, medical school and early residency, I did see people with that rheumatoid hand in that foot picture that I showed you. Crazy deformities. But as the DMARDs proliferated and more came out and more people started taking them sooner, we just don't see that anymore. People just don't get to that level of deformity anymore because they get on these drugs, which reduce the rate of damage to cartilage and bone. So while these drugs do have side effects, in an ideal world, we wouldn't need them, they are very effective. So the traditional DMARDs are Plaquenil, also known as hydroxychloroquine, methotrexate, gold salts is a very good treatment for rheumatoid, and sulfasalazine, also a traditional DMARD.
What? I put it back.
Yeah, you didn't. I need it to the next slide. All right, the biologics. This is what you see all the commercials on, the direct-to-consumer marketing. Ask your doctor about. It's hard for me to say these words, and I don't know why they decided to name these things the way they name it, but they're bizarre words. Abatacept is a T-cell signal inhibitor. Remember, now we're getting more specific with how we suppress the immune system. So we're not doing a global suppression like with steroids. So this abatacept is going to just downregulate a certain type of T-cell signal. The adalimumab is a tumor necrosis factor inhibitor. Anakinra is an IL-1 receptor antagonist used in gout, I think sometimes. Etanercept is a decoy tumor necrosis factor alpha receptor. Infliximab is a tumor necrosis factor inhibitor, so on and so forth. So you can see your doctors are probably picking different drugs based on what they think the fundamental problem is, based on which type of rheumatologic condition or autoimmune disorder you may or may not have. And so they'll try to control just that part of the immune system so that the rest of it functions normally and you're not just wholesale shutting it off. So treatment regimens for rheumatoid arthritis, one of the most common combinations is methotrexate with sulfasalazine with hydroxychloroquine. Why do people use cocktails? Because you can use different drugs at lower doses to get a better effect. So the combination of 3 of these drugs at a lower dose will give you a better result than methotrexate at a high dose. And if you have multiple drugs at lower doses, your chance of toxicity is reduced. So that's why a lot of times you'll be on multiple drugs for the same problem instead of one drug. It's really to avoid that toxicity or the side effects of the drug itself, okay? And then the DMARDs, you just have to remember this, it's a lifetime commitment. It's a chronic disease. So the disease is never cured. And sometimes if you come off of the drug, if you don't stay on a maintenance dose, you get a rebound of the disease and it comes back with a vengeance. And this is what a lot of times we're trying to avoid. Those are just your mean doses. All right, what is methotrexate? So methotrexate is actually a chemotherapy or an anti-cancer drug, first used in 1947. That's how long it's been around. What they found was some doctors noticed that a folic acid deficiency seemed to improve leukemia or make leukemia better in kids. So they figured out there's some connection between vitamin B metabolism and cellular proliferation. And so methotrexate blocks the action of folic acid for cancer. It's an immune suppressant. The World Health Organization has actually called methotrexate an essential medicine because it is so life-saving in cancer cases. It competitively inhibits a particular enzyme that then slows down DNA and RNA synthesis. So you basically can like suppress the immune system by slowing down the creation of the proteins and stuff that are involved. A lot of side effects, obviously, nausea, fatigue, blood cell count, fever. You could get infected, breakdown of the mouth skin, rashes, liver and lung disease, and lymphoma. Somebody had asked about lymphoma before. So when you start playing with the DNA and RNA synthesis of cells to treat one problem, you're going to have the side effect of messing with the DNA and RNA synthesis of other cells. So this is a chemical analog of folic acid, so B9. So it gets into the DNA synthesis cascade, which is heavily dependent on B vitamins. B vitamins are a good treatment for most people with immune disorders, by the way, particularly if you're on methotrexate. It inhibits purine synthesis, and you get an accumulation of what's called adenosine. I don't know if you watched my talk on energy and like mitochondrial function. ATP is the energy currency of your body. That's adenosine triphosphate. Adenosine is the building block of that. So when you have 3 phosphate groups on an adenosine, you have ATP. If you have no phosphate groups, you just have adenosine. Adenosine, turns out, is a mediator of many anti-inflammatory effects. Caffeine is a competitive blocker of the receptor for adenosine. This is why it keeps you up at night. Adenosine builds up in your brain and gives you what's called sleep pressure. Caffeine blocks that signal, so you lose that sleep pressure that you should have. But it also prevents the anti-inflammatory effects of methotrexate because it blocks that whole thing that methotrexate does with adenosine. So some people, if like you're a coffee addict, methotrexate may not work as well for you. Also inhibits T cell activation and does a few other things to help reduce inflammation in the body. Plaquenil. We don't really know how Plaquenil works. This is hydroxychloroquine, originally an anti-malarial drug. We do know that it interferes with the lysosomal activity in the autophagy. Autophagy is when cells engulf dead, damaged cells to clean them up and recycle parts. And the lysosome, remember I told you that was that little bag of battery acid that drops in and kills the bacteria. Plaquenil does something along those lines. Nobody's really 100% sure what. And isn't that interesting that we have so many drugs on the market where nobody has a clue how they work, but we're just okay with that. Interacts with your membrane stability, which, you know, if a cell doesn't have an intact membrane, none of the receptors work right, the DNA protein doesn't work right, et cetera, et cetera. And then it'll alter signal pathways. The whole point of Plaquenil is to reduce the production of the inflammatory cytokines. So it's a good baseline drug for most connective tissue disorders. And it's from cinchona bark, okay? So this is, it was used years ago for malaria. It was found that this certain bark from this certain tree seemed to reduce the symptoms of malaria in these subtropic areas. And then the English Navy started putting in a quinine, and that's the gin and tonic, okay? So they would give their sailors a gin and tonic to make sure they got the quinine from the cinchona bark. That's the alkaloid that helps to treat the malaria. So it inhibits antigen presentation, inhibits B and T cell activation. It does all of these things that basically changes the function of the immune system. It does the same thing against the malaria parasite as well. The usual dose is 200 to 400 milligrams a day. When I put people on it, I put them on 200. You do have to look for, there are some retina side effects, and some people it's doses for a very long time. So just keep that in mind. And generally you monitor people, you see them back periodically and make sure there's no side effects. But there are some side effects with this. Hundreds of years successfully for malaria, and now we use it for mixed connective tissue disorder, rheumatoid lupus, etc. Sulfasalazine, again, mechanism not fully understood. The bacteria in the gut metabolize the drug and make the active metabolites. So it's not active until you digest it. And then it seems to inhibit the transcription of that nuclear factor kappa beta I told you about that turns on the inflammatory stuff in the DNA. It induces macrophage apoptosis, so it makes the macrophages die. And it inhibits osteoclasts. So those are the bone chewing up cells. So again, by inhibiting that receptor for the nuclear kappa ligand. So remember before that, rank L was involved in rheumatoid. Rank L is involved here with sulfasalazine. It downregulates it, slows down bone destruction. Doesn't cure rheumatoid, just slows down the side effect. Your typical doses are 500 to 1,000. So now most people will be on some amount of all of these if they're not on one of the big biologics. These are the cheap generic drugs that still work very well for a lot of people. A lot of side effects. There's your list on the right. So a lot of people come see me and they're having a flare-up. Like they generally have controlled disease, but all of a sudden their knee is swollen and hurts. But they're on a DMARD. They've been successfully managing their rheumatoid condition for some time, but now they got a flare-up. So we think the flare-ups are brought about by strain and stress, usually mental stress or some viral reactivation. Most people that have a flare-up have had some sort of significant emotional stress that happened just prior to the flare-up. Why does that matter? It upregulates the sympathetic system, upregulates cortisol, which upregulates all of the inflammatory aspects of the immune system. So some supplements can decrease this inflammation, and that would be glutathione, which is a natural antioxidant. Vitamin D3, there are vitamin D3 receptors on immune cells. Curcumin, which is very antioxidant and anti-inflammatory, found in the turmeric root or in curry foods. N-acetylcysteine, which is extremely good for tamping down inflammation and chelating metals, and the omega-3 fatty acids, which again, if that populates your cell membranes, you don't go down that arachidonic acid cascade, which is damaging. You go down a cascade called resolvin, prohealing, et cetera. It just sounds better, and it is better. And then, of course, giving yourself a lot of fiber and prebiotics will get your gut biome healthier, which produces transmitters and proteins that are anti-inflammatory. So this is why gut health is so important. I know you've heard about it. We haven't even, I need to do a talk on gut health, but it plays into everything. Okay. Okay. Your natural options to treat autoimmune disorders. Let's talk about them now. This is probably what you guys have been waiting for. But now you understand this, the problem. You understand the immune system, you understand the problem, and now this is going to make more sense.
Tell everybody to stand up and shake their leg.
Oh, yeah. Stretch out a little bit.
Okay. I don't know. Some of these questions are wild. I'll just let you get into it.
Okay. So here's my list, short, and this is not an exhaustive list, so don't hold my feet to the fire here. Any natural anti-inflammatory generally helps, just like for people with rheumatoid, they get steroids or Celebrex or ibuprofen. It's not curing the disease, it's just controlling the inflammation. I'm a big fan of natural stuff, so I prefer natural anti-inflammatories. Natural antioxidants to control that oxidative stress and that free electron damage of all cell structures. The omega-3 fatty acids to promote less of the arachidonic acid cascade, more of the healing cascade. Exercise, very, very important. We'll talk about it briefly. A clean, whole food diet where you avoid ultra-processed foods, also very important. Particularly fiber is very important. Olive oil is naturally anti-inflammatory in and of itself and a very good way to sort of modify the disease. So if you're cooking with anything but extra virgin olive oil, I would probably just switch to that. That'll help you a lot. Sleep, 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 sleep. Number one way to treat this. And then stress management. And we can talk about breathing techniques at the end when we talk about questions and things like that, where you can reset your system and sort of down-regulate the sympathetics so you can manage your mental stress. Okay, D3. This is derived from cholesterol, believe it or not. So cholesterol is not as bad as you think it is. It's very needed for the brain, needed for vitamin D3. So D3 is really more of a vitamin. It just got called a vitamin at some point. So 7-dehydrocholesterol is found in the sebaceous glands of the skin, okay? Photonic energy from the sun will convert it to what's called precalciferol, and then that'll get into the liver. It'll become 25-OHD. That's what your doctor should be testing, that molecule, because that's the most reliable indicator of your overall vitamin D3 status. And then that precalciferol is converted to the active form in kidney. This is why people in kidney failure have so many problems with healing bone and bone problems in general, because they cannot really functionally convert to an active form of vitamin D. The vitamin D receptor modifies gene transcription everywhere in the body. It is so important for everything, not just bone health. And it improves white blood cell function. Receptors are on those monocytes I told you about, on the dendritic cells and on the T cells. Low levels of vitamin D3 are strongly associated with autoimmune disorders, particularly for like MS, we'll say, also lupus and rheumatoid, and also with flare-ups. So let's say you had a stable vitamin D for a while, you're on Remicade, and then for some reason your D level dropped, you could have a flare-up. Also, let's say you had something stressful happen. These are the things you need to start thinking about, because you could control a lot of your flare-ups just by keeping your D3 level. I think 40 or 50 minimum. The government says 30, but that's to prevent rickets. So I would go for 40 or 50 for optimal. And those who supplement with D3 and omega-3 have a 22% lower risk of getting an autoimmune disorder. Think about that. So just those two things, which do what? They enhance the innate natural function of your immune system. So it helps keep everything in balance. By being D3 deficient and high in omega-6s, you automatically have a messed up immune system. So just by getting your immune system the way nature intended, you have a 22% lower risk of developing autoimmune. Nice. Okay, so D3 will inhibit the pro-inflammatory cytokine. Remember, those are the proteins that attack by the CD4 cells. So if you have normal levels of D3, you're going to have less interleukin-2, you're going to have less interferon, and you're going to have less tumor necrosis factor alpha. So those are all those damaging proteins. So you will produce less of the, assault weapons that attack your own body. And also the inflammatory activity of the T helper cell 1 or the T cell type 1, which is pro. T cell type 2 is anti-inflammatory. You will have less of this T cell activity, okay? It'll skew your T cell activity to a more healing, less inflammatory state. So think of D3 like a balancer. It'll balance your immune system to, yes, take care of pathogens and any damaged cells, but no, not attack yourself, and also have better self-tolerance. Okay, omega-3, we've talked about this ad nauseum, but it's one of my favorites. So I'm going to very well studied in rheumatoid arthritis and other inflammatory arthritic conditions, also studied in osteoarthritis and very helpful. This is a cell membrane on top. The bottom shows you the pro-inflammatory cascade on the top if you're heavy in omega-6s, and the bottom is your pro-resolving anti-inflammatory cascade if your cell population is filled with more omega-3s. Inflammation is modulated towards a more healing, less damaging cascade. How does that happen, you say? Well, the phospholipids are pulled out of the cell membrane. Phospholipase A2 starts cascade, right? If you have a lot of omega-6s, that gets converted to arachidonic acid. If you have a lot of omega-3s, it does not. Arachidonic acid goes to the COX enzymes, which then become prostaglandins. Omega-3 ends up as a resolvin or a protectin. Doesn't that just sound better? Don't you just want to be filled with omega-3s? This is why the Mediterranean diet, the Okinawa diet, all of those diets that are heavy in omega-3s, people just feel better. They function better. They're more active in old age. They're not as stiff because they have more omega-3s. I'm a huge fan of omega-3 supplements. I take probably 2 to 4 grams a day myself just to stay healthy and for brain health. So your dietary proportion of omega-6 to omega-3 will determine how inflamed you are in general. If you eat a diet of a bunch of seed oils, corn-fed beef, corn oil, ultra-processed foods, and you don't eat wild-caught salmon, herring, or supplement with omega-3, you're basically just setting yourself up for inflammation, constant inflammation, and probably enhancing your autoimmune disorder. So diet's hugely important in this world. And one of the things you can do is supplement if you can't get enough of omega-3 naturally.
Could you just, you want fish oil, if some people take fish oil, but it includes 6, 9, and 3, so you really want to find the one that
some people take a fish oil that has 6, 9, and 3, omega-3. You could do that, but you're honestly getting more than enough omega-6 from the standard American diet. Omega-9, I think, is also basically olive oil or monounsaturated. So really you want a pure omega-3 with DHA and EPA. The two, you don't want an ALA omega-3, which is what's in flaxseed and stuff. You want an EPA, DHA. And then if you're going to try to get it from diet only, be very, very careful because most fish today are farm raised, and guess what they're feeding the fish? Corn. So the fish are now no longer omega-3 replete, rather they are filled with omega-6. So you have to have wild-caught fish. The other problem is most of the water today is polluted. So a lot of these bigger fish like the salmon and whatnot, they're going to be filled with toxins and heavy metals. That's why I supplement with purified, tested omega-3, which is what my product is. So no heavy metals, no pesticides, nothing else, just straight up DHA, EPA. Okay, next slide. All right, so omega-6 high proportion, we talked about this. Most cooking oils, most ultra-processed foods, most grain-fed animals. When I buy beef now, which I do eat red meat, by the way, I don't eat it often. When I do, it is 100% grass-fed. So a trick that the industry will do is they'll say grass-fed, but all cattle are grass-fed up to a point. Then they put them in these horrifying concentrated animal feeding operations, jam them all together. They stand in their own poo-poo all day, and they just feed them full of corn to fatten them up. Why do they fatten them up? Because we all seem to think that a fatty ribeye, marbled steak is so much better for us. What is that a sign of? Metabolic dysfunction in the cow. You don't get fat like that in your muscle unless you're on your way to diabetes. So what they do is they take the healthy, normal cow that was eating grass, which by the way gives them a certain amount of omega-3s, put them in these concentrated feeding lots, give them metabolic dysfunction, and then kill them. And then that's what you and I are normally eating on the standard American diet. I would avoid that if I were you, if you want to maintain an anti-inflammatory life. Same thing with any animal. Make sure they're eating natural things that they were meant to eat. not corn in a feedlot. So the omega-3 you can find in fatty fish. We discussed that. And also in walnuts, also in green leafy vegetables. Again, most fish nowadays very contaminated. I try to avoid it. All right, less pain for arthritis. I can tell you that when I started taking omega-3 daily, I found that I felt looser, more limber, less fluid. Things didn't crack or crinkle as much, and I really just have no pain ever. Because there's fewer damaging cytokines in my body. There's more resolution and healing when I do get an injury. There's less oxidative stress. The brain is healthier. Mood is stabilized because the brain is functioning better. Sometimes you can add primrose oil to this and also help with your pain. And then I'll just briefly tell you that there's a review study out there that looked at 20 trials. You know, they looked at every body of trials. They picked the 20 best. And 16 of them, of the 20 that looked at rheumatoid arthritis specifically, found benefit with taking omega-3. Now, am I saying take that instead of your Remicade or instead of your Rinvoq or instead of your whatever? No. I'm saying do it in addition to. But really change your diet and then take the omega-3 on top of it. Stay on your current DMARD, and I bet you're going to feel a ton better. The recommended dietary ratio of 6:3 to be sort of healthy is 4:1, okay? Our ratio is 15:1. It's horrific what our food industry is doing to us. So only you have the power to change that. No one's going to fix it for you. Curcumin, one of my favorites. So this is turmeric. You guys probably, if you're not on turmeric, I'm sure you know somebody that is. Highly anti-inflammatory. Blocks the enzymes, like cyclooxygenase enzymes we talked about, that take that arachidonic acid from the omega-6s and converts it into prostaglandins, which are the inflammatory little molecules that actually do the damage. So curcumin will block that enzyme, just like, guess what else? Ibuprofen, Aleve, any NSAID. That's where they function, okay? But curcumin has far fewer side effects. A single dose of anti-inflammatory has been shown to basically just destroy your gut biome. And also, it's got to be processed through the kidney. Anybody with heart disease or ischemic heart disease can't take anti-inflammatories because some of the prostaglandins are needed for cardiac function. The natural anti-inflammatories do not have these side effects. That's why I love them so much. A British medical journal study showed pain reduction in arthritis. So they studied it in knee arthritis and found that, yes, in fact, in a study of 139 people, it was very effective in reducing pain. And guess what? Fewer side effects than the synthetic drugs that are pushed out and sold at all drugstores. You can actually get mild weight loss with this, and it can prevent bone breakdown. So whole turmeric is pretty much often contaminated for the same reason we talked about. A lot of it's grown in foreign countries where they don't have an EPA. And so there's a lot more pesticide use and a lot more metal in the soil. So the purified extracts tend to be chemically safer and tested for these things. So like the turmeric that I offer for people is a 95% purified curcuminoid to avoid all those contaminants, okay? And then there are some side effects at very high doses, not normal standard doses: nausea, dizziness, diarrhea. It will reduce 5-alpha reductase activity. So in some men, I advise against it. And then there is some interaction with warfarin in the liver. So people that are on warfarin, which is a very old school blood thinner, generally are told not to take turmeric or curcumin.
What about Xarelto?
Xarelto works an entirely different way and is metabolized with a different liver enzyme, and I don't think that Xarelto has the same interaction with curcumin. It has to do with how warfarin is metabolized in the liver by the cytochrome P450 that breaks it up. It's the same one that works on curcumin, but I don't think Xarelto has that same effect. But I'll fact check myself later, and if I'm wrong, we'll put up a comment. Next. N-acetylcysteine, okay? This is actually made by you in your own liver. It's when cysteine, which is an amino acid, is altered. It is also found in very high protein foods. So you can get it naturally if you eat enough meat. The dosing for supplementation is anywhere from 250 to 2,000 milligrams a day. And in those studies, no adverse events were reported. There will be an increased excretion or urination of zinc. So if you're taking N-acetylcysteine chronically, you definitely need a zinc supplement. Zinc's a cofactor for pretty much everything in the immune system anyway, all of the little chemical reactions. So like for my patients, when they're healing a surgical wound or they have these inflammatory conditions, I highly recommend that they're on zinc anyway. It's in my connective tissue multi for that reason, because it is a cofactor and it's so integral to immune system function. So while N-acetylcysteine will help with the inflammation and act as an antioxidant and help you out, you can't forget the basic minerals. You need to be on zinc too. N-acetylcysteine started its life out as an antidote for people that overdosed on Tylenol, and it protects the liver that way and helps save a lot of lives. It's basically an amino acid that supports the creation of other antioxidants in the body. So N-acetylcysteine is very supportive of, say, glutathione production. So if you don't have enough N-acetylcysteine, you're probably not going to have enough of your innate natural antioxidants, which will, of course, lead to cellular failure, and then your immune system goes downhill anyway.
We have this in the answer.
Yeah, the N-acetylcysteine I put in my nervous system multi because it's so integral to good brain health as well.
Which also has the omega-3.
Yeah, the nervous system multi, I could probably rename the immune system multi. Everything in it is very helpful for immune function as well. All right. So NAC, which is the nickname for N-acetylcysteine, prevents the oxidation of glutathione, so it supports glutathione formation. It also helps in the production of glutathione because it helps connect the cysteines together, which is the fundamental amino acid that makes the antioxidant. It also scavenges free radicals, so it picks up those extra unpaired electrons. And effectively, it will minimize any muscle fatigue. That's why it's great for autoimmune disorders, right? Remember all of those symptoms? Most people have some sort of muscle pain or muscle fatigue. And it reduces levels of lipoprotein in the serum, so it actually helps with your cholesterol levels, believe it or not. And people on NAC, it's been shown, have fewer flu symptoms, or if they get the flu, it doesn't last as long and it's not as bad. And it also improves mood. Specifically, it's really good at reducing ruminations. So remember I told you a lot of these autoimmune disorders are associated with mood problems or depression. That's because of the inflammation that it affects the brain. N-acetylcysteine is very good for that. And it's also good for things like, and so they're studied it in some kids for like nail biting, hair picking, this kind of like repeated motions over and over and over again. And the ruminations, the repeated thought, the perseverations. But again, this is not a psychology talk, natural substance. NAC is, think of it as just really good at building up your own antioxidants, and it acts as an antioxidant itself.
Before you get to that, is curcumin and turmeric similar or two totally different things?
Question is curcumin and turmeric similar, or are they two totally different things? Curcumin is the active ingredient of the turmeric root. The turmeric root is a source of curry. So whenever you go to an Indian restaurant and you have a curry, that is from turmeric. You probably have turmeric in your spice cabinet. It's basically just the ground up root. Hopefully it's been tested for heavy metals. Curcumin is merely one of the active phytochemicals in the turmeric root.
You had mentioned zinc. Karen says zinc reduces the effectiveness of Rinvoq, causing flares.
Karen says zinc reduces the effectiveness of Rinvoq and will cause flares. So that's interesting because zinc is very fun on the rest of the immune system. I'm not sure at what level zinc does that to Rinvoq, but I'm certainly going to look that up. Okay, B vitamins. We talked about this already. Remember, methotrexate messes with the B vitamin synthesis, which is one of the ways it works for cancer, one of the ways it works for rheumatoid arthritis. B vitamins support DNA synthesis, and support nerve cell function. When I have patients with neuropathy, one of the first things I do is I run a B vitamin panel. I also look at other electrolytes too, and other vitamins. But B vitamins are so fundamental to nerve health and brain health and DNA synthesis that I think is one of the first things we should look at. And then remember, the targeted methotrexate is a process in the folate metabolism. These are water-soluble substances, and so you pee them out every day. So if you're not eating enough every day, you need a supplement. I take a B vitamin every day, complex, all of them. And they assist the anti-inflammatory drugs with pain relief. So by enhancing better nerve function, you're going to have less pain. And everything works better if your DNA works better, obviously. So this is why B vitamins are so fundamentally important. A lot of the drugs that target the, not a lot, a few of them focus on the B vitamin pathway because it slows down the synthesis of the harmful cytokines. So B vitamins are very, very important for proper function of nerves to help reduce your pain and also to help your immune system do what it needs to do, particularly the regulation and the balance. Alpha lipoic acid, another good one, strongly anti-inflammatory and antioxidant. And it will actually be an antioxidant in both the lipid membrane because it's able to mix with fat, and also the cytosol, which is more water-based, it's able to mix with water. So it's kind of a mix between oil-based and water-based paint. It'll help antioxidize in both structures, which usually antioxidants are either water soluble or fat soluble. Like vitamin E is fat soluble, vitamin C is water soluble. Alpha lipoic acid can go both. It can go both in the cell membrane and the cytosol. It supports the function and the restoration of used up glutathione. So it helps keep your level of glutathione normal, which is, again, your primary self-made antioxidant. And it's awesome to treat neuropathic pain and rheumatoid pain. Alpha lipoic acid is one of the first things I recommend to people with neuropathic pain. It's a first-tier treatment in Europe again. Not known by a lot of physicians in this country because our medical schools are so heavy on pharma. But ALA is very safe, and it's just a great drug for brain health and nerve health. And if you have any sort of nerve-based pain or any pain that's related to oxidative stress, you should probably be on ALA. And it also, surprisingly, helps keep your blood glucose levels normal. So it's actually a great drug to help with weight loss and diabetes management as well.
Before you go in.
Never mind. So glutathione, we talked about that. It's basically formed from cysteine, and it's got sulfur, a thiol group in it. This is an extremely powerful antioxidant that you're making it right now. It's being used right now to detox your body. So there's a thiol reduced form and a disulfide oxidized form. It's found mostly in the cytosol. Okay, remember that's a water part of the cell. There's some found in the mitochondria, which is, of course, the engine of the cell. Most of this is made in the liver. So if you have fatty liver disease or dysfunctional liver, you probably don't have enough glutathione, and you should probably be on everything that increases your glutathione. Okay, the bottom picture shows you all of the damage that we are faced with every single day, never mind what we eat. And so it's important to have a baseline of antioxidant levels just to sort of support our generally terrible diets. Even those of us like myself that read about this all the time and try to eat as healthy as we can, I'm not perfect. I make dietary mistakes all the time. I try to make up for it by taking antioxidants. It's always going to be better to get it naturally from food, but I think supplements have a huge role to play in this world where we live in, surrounded by chemicals and pollution.
Barbara, she's taken the tart and the PEA for inflammation and joint pain. Speaking of new antioxidants, the pterostilbene supplement.
Okay.
What do you think about that one? And then is it possible?
This is a really long question.
Is it possible to overdo supplements? Like, can some of your supplements counteract each other?
This is a very long, complicated question.
They can read it. Okay,
you guys can read it. Pterostilbene works the same way as resveratrol generally, but it's considered to be a little bit more easily absorbed or bioavailable. I take resveratrol and pterostilbene, but I'm taking them for longevity and anti-aging purposes. But they're also good for antioxidant and cleaning up your cell health. Can you take too many supplements? I suppose if you take pounds of it every day, all day, and you're not balancing it out with a normal diet. Can some interact with the others? Of course they can. And then everything is also dependent on your particular liver, okay? So for instance, 7% of Caucasians lack one form of one of the cytochrome P415s, and so they can't metabolize narcotics properly. So that subset of people, you take a lot more pain pills than another person to achieve the same level of comfort. So they're often mischaracterized as having a problem, but really they have a genetic defect. That's one example of a liver enzyme problem. So yeah, if you don't have the liver enzyme to metabolize, let's say turmeric, the same way as normal people, maybe a lower dose is needed for you. That starts getting into genetic testing and everything else, which some of it frankly doesn't even exist, certainly not to the general public. But I think at the doses that are normally recommended, I can't think of any study that shows any adverse effects or any major changes in the function over time. Glutathione, that's what I want to talk about right now. Again, your natural, this is what you're making every day that's detoxing you as we speak. So converting hydrogen peroxide, that's a free radical water, okay? It basically helps to regulate the cell cycle of life, okay? And the cell cycle of life is where you take food and convert it into carbon dioxide and water and make ATP, okay? And this just goes on and on and on. You eat food, you breathe out carbon through carbon dioxide, you pee out the water, you use the energy, that's converted into either movement or heat, right? This is your cycle of life. It never ends. It's an antioxidant defense because in the process of that ATP, in the process of converting food to movement and heat, you produce side effects, exhaust out of your engine, which is the free radicals. So the glutathione neutralizes those free radicals and helps prevent cell damage. It'll maintain the proper membrane potential, which is what drives energy production. So you want more positive here, more negative there, then the positives flow through this particular turbine that makes energy. And it will modulate immune function, of course, and change the formation of fibrogenesis. So this is why it's good for autoimmune disorders, which are often connective tissue disorders. So let's sum it all up, if we can. Wait, going backwards. So as you can tell, this is a very complicated topic, obviously. The treatment is very complicated. It ends up being a bunch of different cocktails. You change a bunch of things, and there's many side effects. Nutrition, exercise, sleep, and stress management are important. I didn't get into exercise that much. Exercise will pull glucose out of the blood, which helps. It'll regulate your insulin production, which helps. And it'll actually, through the mild stress of exercise, your cells become more resilient and able to respond to stress. By strengthening your muscles, you support and protect your joints. You also develop what's called tissue tolerance, which lets your connective tissue handle load over time. So for instance, if I wanted to run a marathon today, my tissues don't have the tolerance to do it. It would hurt. I would get injured. But if I trained properly over time, I would develop tolerance and then I would be able to run a marathon. The human body adapts and is plastic and will change to whatever new environment or situation it's in. You just have to give it time to do so. So exercise is very, very helpful for the disorders associated with connective tissue and joint dysfunction. I didn't mention obesity in this talk. Obesity is highly associated with flare-ups and enhanced activity of autoimmune disorders. Why? Because obesity produces cytokines, which are inflammatory. So if you can get your obesity under control, that helps reduce the inflammation, which helps reduce the symptoms. The supplements we talked about, very, very helpful. Should probably not replace your treatment plan, but should be used in conjunction with it. If you have poor sleep, I would go get a sleep study if you can get a doctor order it, because sleep is your body's primary time to do cell restoration and repair. It doesn't do it while you're awake and never will. You have to sleep. So if you're going to fix anything, you have to get good night's sleep. So one of the first things you can do for yourself is a sleep study. And then remember, this is a non-communicable chronic disease, which means it's chronic, which means it's not curable, but we can manage the symptoms to the point of remission, really. But sometimes, remember we talked about the response after about 5 years and 3/4 of people diminishes. You may have to change drugs over time or change your cocktail, but you should be able to control the symptoms with the proper regimen, assuming you have the proper diagnosis. And then the supplements that control the overall function of the immune system that we just talked about will help those drugs work better, in my opinion. So hopefully that gave you sort of an idea of what autoimmune disease is and things you can do to modify and control your symptoms, and then how the drugs work. And if you guys have any specific questions that I did not answer, we can answer now.
Okay, you ready? Kara, she's been on with us before. Can surgeries and injuries cause inflammatory markers to be elevated?
The question is, can surgery and injury cause inflammatory markers to be elevated? Yes, but each of them have a half-life. So like after surgery, we can expect an erythrocyte sedimentation rate, or the ESR, to be elevated for anywhere from 2 to 4 weeks. And your CRP is days. So like if I'm looking for, let's say, infection after surgery, I'll get an ESR and a CRP. If the ESR is up and it's within that time frame, I don't get too worried. If the CRP is really high, I get worried for infection. Some people have a low level elevated CRP to begin with because they're inflamed. So unless you know your baseline CRP before the injury or surgery, it's really hard to say. But the short answer to the question is yes.
What if it was 6 months ago now?
6 months ago, they should not still be up.
Because basically, when it comes to her, she wrote this long thing, like her SED rate and C-reactive is elevated, but her RA factor is negative, and she just has stiffness and swelling in knees and back and neck stiffness.
Does she say how old she is?
Ask Kara.
Kara has stiffness in multiple joints, a high ESR, a high CRP, negative rheumatoid factor and ANA. So if this person is in their late 40s, 50s, 60s, I would consider they have probably polymyalgia rheumatica, which that's how it presents. It has high inflammatory markers of the non-specific sort, the ESR and the CRP, and everything else is negative, and proximal joint stiffness and spinal stiffness, especially in the mornings. That usually wears off after a little bit of time. These people are generally, unfortunately, managed with prednisone. That's really the state of the art right now. Maybe Plaquenil, but that's probably what I would look at if you were in my office and sort of go down that pathway.
She's also on Zoloft.
Yeah, so Zoloft is a mood, like it's an SSRI, right? Serotonin reuptake inhibitor. So again, most autoimmune disorders are associated with some sort of inflammation in the brain, which we now think is the primary source of depression and anxiety. So it makes sense that somebody that might have polymyalgia rheumatica may or may not have a mood disorder. That's sort of, they go together often. But that's what I would look for.
And then, do you think it's okay to take Zoloft while taking methotrexate? It's the same lead.
Yeah, so the question is, can you take Zoloft with methotrexate? I mean, the caveat here, please check with your physician. You know, I'm doing this as value add. I don't want to get accused of anything. Always check with your physician, but I've seen plenty of patients on methotrexate and Zoloft. I've never seen an issue with that.
Okay. Karen here, she's just excited that you're local. And she says, I take naproxen to help with chronic inflammation in RA. I'm concerned of this messing up my gut. Any suggestions? But I'm sure she heard the other ones. But
so this person's taking naproxen to treat chronic pain in RA, it sounds like. And she's concerned about the side effects, which you should be. So over time, those drugs can damage the kidney. I mean, you can do blood work once a year and pretty much rule that in or out. So that's your relief valve there. It does destroy the gut biome. What I would say is make sure you eat a lot of fiber or add fiber to your foods. Eat a lot of fruits and vegetables to help build back the gut biome if you're going to stay on the naproxen. My patients, I try to get them on a baseline level of inflammation control with natural stuff in the hopes that they take the synthetics less often. I'm never going to say don't take Celebrex or don't take naproxen or don't take Duexis because they're great drugs and they work really well. It's just you don't want to be on those on a daily basis. It's better to be on natural things for baseline control. And then if you still happen to need a Celebrex or a naproxen periodically, great. But you're not taking it every day. So it's better for your kidney, better for your heart, better for your gut. We're looking at another question.
Yeah, you could just tell them, get the last questions in.
We're trying to get your last questions in. We're sorting through them right now.
Kara was 57 with a negative CCP serum.
Yeah, negative CCP. CCP is very specific for rheumatoid. So yeah, for that person with the ESR, CRP, negative CCP, negative RF, negative ANA, I would go down the path of polymyalgia rheumatica.
Her roomie says she's too young for it and thinks either RA or psoriatic because I had pain in my knees, that stiffness and cortisone shot helps swelling.
Yeah, so she's seen a rheumatologist, which is good, and they're probably going by their algorithms and the criteria. So that's fine. I mean, they're obviously going to know the history and the story and the blood work better than I will today. All right. Do we have another question?
Hold on.
Hold on. We're perusing. All right. While she's looking at questions, see what I can tell you.
Tammy has high histamine since she had COVID. Any advice besides leave everything alone?
Somebody has high histamine levels since having COVID, and is there any advice from me besides leaving everything alone? So maybe PEA might help that because it reduces mast cell degranulation, which is of course where the histamine is coming from, unless it's a basophil cell problem, which is less likely because basophils are more responsive to parasites. So maybe PEA, and then again, a natural whole food, hopefully mostly plant-based with some meats diet will really help.
She's taken the Tart and PEA, and she believes she's getting relief, but it's only been a couple of weeks.
Oh, yeah, this brings up a good point. So this person's been on PEA and Tartary just for a couple of weeks and is already feeling relief. I don't expect people to feel relief from natural stuff for anywhere from 60 to 90 days because it's natural. So it takes a while to get into the system and change things at the fundamental cell level. Most of the synthetic drugs out there shut down completely one enzyme, so things happen dramatically and quickly, or they completely block one receptor right away. That's why people that take Percocet feel euphoria and instant relief because immune receptors are hit hard right away, as opposed to people that take natural pain relief like omega-3, which it takes about 90 days to populate your cell membranes with the omega-3s. It doesn't happen overnight. So that's great if you're already feeling relief. But that's my favorite. One of my favorite combos for arthritic pain is turmeric in the morning, the joint health multi in the morning, tart cherry at night. Briefly, we didn't talk about gout, but the meds for that are colchicine, which inhibits neutrophils, and then of course steroids. So gout's another common autoimmune that I see a ton of, which is urate crystals that deposit in the joint, primarily from purine problems, which we used to think gout was just too much red meat, too much crawfish, but really it's fructose. So people that drink a lot of juice are at risk of gout. So just keep that in mind.
Penny, how do you feel about Cimzia and side effects to treat arthritis?
Cimzia.
Cimzia. I don't know.
Oh my goodness. I knew somebody was going to ask a specific question about a specific drug that wouldn't be on my list. There's so many DMARDs out there. Cimzia, I don't have that. No, I have it. That's anti-tumor necrosis factor alpha. So that's just going to reduce that particular cytokine, right? So that's one of those specific immunosuppressants, which is actually better than the big systemic suppressants like steroids. So Cimzia is going to, like Humira, like Simponi, and Enbrel, regulate your tumor necrosis factor alpha, which is the damaging cytokine produced in the setting of autoimmune dysregulation. So I think that's probably a fine drug. You just got to get it dosed right.
That's the last one. Can stress and depression cause elevated inflammatory markers?
The question is, can stress and depression cause elevated inflammatory markers? I would say stress can, but depression is resultant from elevated inflammatory markers. So mental stress will upregulate the sympathetic system and cortisol and get you into that hyped up fight or flight state chronically, which will induce inflammation, which will induce your inflammatory markers. The current theory of depression, or one of the current theories, is that it's actually an inflammation-caused problem. So too much inflammation in the brain, too much oxidative stress causes mood instability. So I would say having depression doesn't mean you're going to have high biomarkers for inflammation, but if you have biomarkers for inflammation, you're probably at risk of depression, if that makes sense. So anything you can do to reduce brain inflammation will help your mood. Omega-3s, for instance, NAC, for instance, ALA, for instance, PEA.
What are your recommendations for fibromyalgia?
What are my recommendations for fibromyalgia? Avoid glutamate. Don't eat anything with monosodium glutamate or any foods that are heavy in glutamate because that upregulates the excitatory neurotransmitter glutamate, which increases muscle pain and that tenderness that people have with fibromyalgia. And then, so a lot of people go on more of a plant-based diet. Okay, that's one thing, but really just avoiding that, anything that elevates the glutamate. Okay, and then exercise. Avoid deep tissue massage. You got to go get a sleep study. Maybe take CBD to help you sleep at night. I put a lot of people, or I recommend medical marijuana for my patients with fibromyalgia because it upregulates the endocannabinoid system, which helps tamp down and regulate this hyped up pain thing that happens with fibromyalgia and also the mood. And then if you watch my fibromyalgia talk, I get into this in depth. I have a D8, a Delta 8 gummy that really helps a lot of people with the neuropathic pain associated with fibromyalgia and also helps with the sleep. So there's a variety of ways to handle fibromyalgia.
All right. The Kara, the one that you thought, she says they're nervous about being put, she's so nervous about being put on methotrexate. They said her RA is at the beginning stage, so I'm sure it's a low dose, but I'm really scared of cancer.
Well, yeah, okay.
But has she tried the natural?
So somebody that has early stage RA is being started on methotrexate, and they're scared of getting cancer. I think your physician, hopefully, yeah, put you on a low dose and monitor you. You probably need to take a folate supplement with it or a B complex. We have a B gummy. They may want you on something different, but start with that. And then just make sure you maintain a healthy diet, get good, clean living, sleep well at night. All of that helps prevent cancer. Avoid toxins, don't smoke. And your risk from taking low-dose methotrexate to treat a dysregulated immune system of getting cancer is not going to be that much higher. Speak to your physician, obviously. I'm just saying in general, if you suppress the immune system, then you're also suppressing the body's ability to attack abnormal cells. Specific problem with a specific subset of cells with a specific disease and you're low dose managing that, that's kind of a different story.
All right, one more.
One more question.
How to support adrenals?
That's a big question for the one more question. Wants to know how to support adrenals. I'll be honest, that's a whole nother talk. Adrenal, ACTH, the hypothalamic pituitary axis. I mean, I can't even begin to get into that. If you really think you have adrenal atrophy, which is rare unless you're on like chronic steroid use, I guess the usual things that help: diet, proper sleep. But if you're on chronic steroid use and you've suppressed your innate production of corticosteroids, you basically can't come off the steroids because you will have no corticosteroids, and then you will be truly atrophic in the adrenal world. So I don't know where this particular adrenal insufficiency is coming from, but that changes everything about it. And if you guys want, I'll do a talk on that, but that is whoa, that is a big topic.